conference or speakers. First one is Dr. Jun Mao, Lawrence Rockefeller Chair in Integrative Medicine, and he's the Chief of Integrative Medicine Service at the Memorial Sloan Kettering Center in New York, one of the best oncology centers worldwide. Then we will have Dr. Gabriel Lopez, who participated in some panels yesterday. Gabriel is Associate Professor of Integrative Medicine Center at the MD Anderson Cancer Center in Houston, Texas, another excellent hospital. And we will also have Ricardo Ballesteros as speaker in this GAT program of Pontificia Universidad Javeriana, and he will share with us some of his findings and results in such an interesting research he's doing. Before starting, do you have any comment? Good morning, Alejandro. Good morning to all of you who are present and who are virtually connected. Just to highlight that this is a panel that I believe it's very interesting for the attendees. And we have guests, as Alejandro well said it, from two of the most important centers worldwide, cancer treatment centers, perhaps the most important cancer centers in the USA. Combined with the local experience, it's going to be very interesting to see how in these centers research is developed and what possibilities do we have to work in that process of creating knowledge, given all the situation we have in our Latin American countries. Thank you, Raul. Okay, so we will start with Dr. Jun Mao. So, Dr. Mao, you have the floor. Colegas, qué bueno compartir con ustedes. Primero que todo, pueden.
Wonderful. I wish to be with you in person. And Alejandro, thank you so much for serving as bridging integrated oncology across the globe. So I'm going to talk a little bit integrated oncology, evidence-based medicine, patient-centered care. Hold on a second. My slides are not advancing. 1 second. It was working before. What happened? Okay, great. So ours integrated medicine service was established in 1999. Actually, by next year will be 25th year. So when it was first established at the time, there's no integrative medicine, integrated oncology is what's known called alternative medicine or complementary medicine for some people. It's really people just using things from their culture, tradition in a very unsupervised way, and often it contraindicated with conventional oncology. But recognizing the potential value of this, MSK taken an important step to establish a service to begin doing research and help to bring the service in a comprehensive way in the context of unconventional oncological delivery to help people support symptom management, quality of life, and adherence to conventional cancer treatment, ultimately to improve the life, not only the quality, but also the length for individuals impacted by cancer. So I'm blessed to work with close to 60 faculty and staff in my center. So this work definitely not reflect just myself alone. So in about 2016, 2017, a group of the leaders in Society for Integrative Oncology, we decided it's time to define the field after we have been existent for almost 20 years. Because a lot of the commercial entity want to, take advantage of the term for, unsubstantive use of alternative medicine for marketing to make money. But really, our existence is to serve the patients in the most evidence-based and patient-centered way. So this is actually a result of large engagement from the integrated oncology community, from membership, as well as from conventional medical, surgical, and radiation oncologists and oncology nurses. So we have this definition. Integrative oncology is a patient-centered, evidence-informed field of cancer care that utilizes mind and body practices, natural products, and or lifestyles modification from different traditions along conventional cancer treatments. Integrative oncology aims to optimize health, quality of life, and outcomes across the cancer care continuum, and to empower people to prevent cancer and become active participants before, during, and after cancer treatment. So what really separates us from alternative medicine is this evidence-based approach. So as many traditional medicines such as herbal medicine, traditional healing practices, or acupuncture, yoga, has been around for like 3,000, 4,000, 5,000 years. So there's a wealth of clinical experience in the community. But we really need to continue to develop the clinical experience of delivering those care in the context of oncology practice. Clearly, like large survey study document, up to 7% of patients utilize this as approach. So this is an area where tremendous patient preference and values, right? So where it is lacking is the research. So I'm going to emphasize the need to produce rigorous research, ultimately really build this field forward. So this is due to the Alejandro Center only give me 15 minutes. So I'm only highlighting one study to show you as an example how we can conduct rigorous trials to publish in high impact journals, ultimately become guidelines to change care. So this is a trial I led and published in 2021 in JAMA Oncology. But the work leading to this trial, it took about 15 years from doing the phase 1 trial to phase 2 trial. So this particular study to evaluate two forms of acupuncture, electroacupuncture and ear acupuncture, also known as auricular acupuncture, versus usual care for patient-reported pain in cancer survivors with chronic musculoskeletal pain. Our primary hypothesis is both forms of acupuncture will produce greater pain reduction, pain intensity to usual care at 12 weeks. And the secondary hypothesis, auricular acupuncture will be as effective as electroacupuncture to reduce average pain intensity. So the three forms of intervention, one is using electric stimulation of the needles around body area where it's pain. The others use very standardized protocol of auricular acupuncture, also known as battlefield acupuncture. The last one is just oncologists or nurses prescribing pain medications or physical therapy. So intervention lasts for about 10 weeks. Then we follow individuals for additional up to week 24. So we have long-term follow-up data. So here's the primary result. If you can see that the darkest gray is the electroacupuncture, the lighter gray is the auricular acupuncture. So both forms of acupuncture caused substantial and statistically significant reduction in pain compared with usual care at week 12. And that reduction in pain persisted over time despite no more acupuncture was produced. So our conclusion is acupuncture resulted in clinically meaningful and statistically significant and sustained reduction in pain. And if you look at the specific magnitude, electroacupuncture reduced the pain by about 1.9 points compared to usual care, and auricular acupuncture is about 1.6. Unfortunately, in the non-inferiority testing, we find auricular acupuncture was not non-inferior, meaning was not as good as electroacupuncture reducing pain, but the absolute difference in magnitude pain is relatively small. Where potential reason for that is in ear acupuncture, it can be quite sensitive. About 10% of the people could not tolerate it, therefore led to substantial higher rates of discontinuation in the ear acupuncture. And in the electroacupuncture, really the adverse effect is very mild. And but also we found, in addition to pain, both interventions improved pain-related functional interference, improved physical and quality of life, reduced the pain medication use, and the reduction in pain medication was persistent. I'm not sure about Colombia. In the United States, we have a opiate epidemic. There's too much opiate-related misuse and death. So as a general medical practice, we're really advised trying to not prescribing too much pain medication, especially for patients who have already finished cancer treatment, surviving cancer. We are now moving away from opiates. Certainly, opiates still play a huge role in palliative care and end-of-life cancer care. So I don't want the message to be, but for survivors who are cancer-free, we really want to move towards non-pharmacological interventions, use minimal amount of pain medication as possible. So with research like this from our group, as well as MD Anderson and others, so now acupuncture is recommended for adult cancer pain, nausea, vomiting, fatigue, to be used in palliative care and survivorship setting for things like hot flashes in women with breast cancer. So this cannot be possible without the folks spending a lot of time and effort doing research. So clearly research changed clinical practice. So I want to highlight a few areas of our ongoing work and also outreach to the broader community. Even for folks in Colombia, you can take advantage of some of the resources we have. So as part of the COVID pandemic, we developed an online exercise and meditation programming, so-called the Integrative Medicine at Home. This program so far has registered over 100,000 class participants from 23 countries. So we are conducting both quantitative and qualitative research to really evaluate the impact. And for example, one person have illustrated how important to have this structure to help cancer patients maintain healthy behavior, such as, yeah, it's great because when I try to exercise on my own, it's just not regular. This kinds of keep me moving. And then also the impact of surrounding by people with cancer guided by providers in doing meditation or music therapy or exercise provide a lot of mental support. For example, a lot of time, the problem is you have all these racing thoughts. The classes really help me focus on the current session rather than all the anxiety related to cancer and cancer treatment. And last but not least, cancer can be an incredibly lonely experience. Often in many society, it's still very stigmatized. So here you're surrounded by people who are traveling around the same journey. It really helps to foster social engagement. So patients saying, keep you feel like you're connected to a community, some fellow patients you happen to see attending the same session. So it's a platform for people to continue to interact that way. So we are currently conducting a large randomized trial in this setting. to further to support the evidence of virtue over the mind, body, and fitness patients. We also maintain an online meditation station. Again, if you Google MSK work meditation, so for in the during chemo infusion or they are waiting for their MRI scan, those can be incredibly anxious moments. So patients can should access this on their iPad or phone to really engage some guided imagery or meditation exercise. Again, we need to think about innovative tools to reach more people. Both are seen in places like MSK and out in the community. We also have online professional trainings for providers such as practicing acupuncture, yoga, physicians, or oncology nurses. So we have trained over 1,000 participants from close to 40 countries through this methods. Again, I do think really receiving systematic rigorous training will help to bridge our care, really bridge traditional medicine and conventional medicine. And certainly Latin America has such a rich cultural tradition and traditional use of many herbal agents and spiritual healing practices that I'm aware. So look forward to collaborate with colleagues to do research and incorporate those in our training of research to develop culturally relevant practices for people residing in Latin America. Also in America, a lot of people are from Colombia or from South America, Latin America region. We really need to develop practices more culturally attuned to those individuals. And last but not least, our center maintains one of the largest and most well-accessed database on herbal information. So we have over 280 herbal monographs, and you can access through our website. Just type MSKCC about herbs, or you can download the apps. Actually this slide needs to be updated. We have over 300,000 app download. So we have, actually today we have over 10 million visitors from 228 countries and regions have access to this resources, and some of our website are translated in Danish or other languages to be utilized in the cancer control effort by specific countries. So I really welcome the continued collaboration and individuals in Colombia or other Latin America, so we can continue to develop evidence-based integrated oncology for the world. Thank you so much.
Muchas gracias por haberme dado este espacio. Thank you, June, for an excellent conference. And also for sharing all your resources. My own experience, it's an excellent collaborator. When I decided that I wanted to work in integrative oncology and create a problem, the first two people that I met was Yun Mao and Gabriel Lopez. And since then, we've been together and collaborating together. Yun has trained lots of people all over the world, and Colombia and Latin America is here for take advantage of that great advantage. I will wait together with Raul for questions once all the speakers have talked, and that way I can have questions for everybody. We will continue with Dr. Gabriel Lopez. Yes, we can hear you well. The presentation, it's on me, or you can go ahead, doctor, and use your presentation and handle it from your side. If you have any problem, let us know, Dr. Lopez, because we have your presentation here too. Okay, he's going to try. Okay, there they are. Thank you very much again for inviting me. I'm very pleased to be able to be here and with Dr. Mao following him. It's a colleague. We've worked together a lot in collaboration with catering and together with the Society Friend on Oncology and to advance knowledge on this area of integrative oncology. I will talk about our program in more detail about Dr. Young talked about the definition of oncologic integrative medicine. I'm going to talk about our program from integrative program in a clinical center like a clinical lab. What does this mean? Each interaction that we have with a patient, offering him or her a treatment or a consultation in the integrative oncology medicine, it's an opportunity for that patient to contribute with the general knowledge of this area of oncology. And it's a great opportunity for us to learn more about that intervention, about that consultation, if there are interactions with the patients where we have this wonderful opportunity to obtain first-hand information that we can use it in the research. It's if we cannot use that, it's a lost opportunity. So our emphasis is that whenever we interact with patients, the patient is contributing to the general knowledge of integrative oncology medicine. So what I would like to share with you is everything that we've been able to do through the strategy that we've used to create this clinical lab. To tell you a little bit more about our program, we have three main branches, which is the outpatient consultation, a research group, and training group or education group. And the outpatient, we have our lab clinical, where we learn about to interact with our patients. Why patients come to our clinical center? Well, that's something that each patient, whenever they come to our center, they have something in common with all the patients. For us to see our patients in our integrative patients, has to be a patient from MB Anderson. He cannot come to our center just to cure his cancer and have the oncologic management. It's a group of oncology, medical or surgical group, but patients normally, when they are referred to, our patients to our center, they are asking the opportunities to improve the quality
to enlarge their life, alleviate the symptoms, avoid recurrence of cancers, and somehow help the treatment, the conventional treatment that works better, or by recommendation of a friend or a family member. Some patients do not understand why, but they say, oh, well, my friend, my family, they know we're here. Why we're here, talk to them, and they will explain to you why they are interested in integrative medicine. So it is important to understand why the patient comes to you and what they think and why the oncologist or the medical group decided to refer that patient to the Integrative Medicine Center. The philosophy of our program, June before described the definition of oncological medicine, which is the global definition of integrative medicine. Now I'm going to talk to you about our philosophy. The Integrative Medicine Center works together with the oncology group to build a personalized program that is safe and based on evidence with the objective to improve the clinical results. And that is key because it is a customized, personalized treatment that is safe and based on evidence. At our center, as I said before, we have outpatient consultation, the education group, the research group, and as part of our clinical center, which is called Innovative Medicine Center, we have different branches to support the patient. We offer them information on our webpage. There's also publications that we have. We also have offerings, like for example, we have group classes for the patients for measurement and yoga too. Yoga meditation classes are given through the internet. Those are pre-recorded classes, or also they can also be live classes. The general philosophy of our program is based on the biopsychosocial model that was first published by Dr. George Engel, and we are focusing on supporting patients in the mind body area, physical components, and also support them in the social aspects. And when we think about supporting the patients and when we have decided what are the interventions and the components that we wanted to include as part of our team, it's always been thinking about these fundamental or basic aspects on how we can support the patient from the biopsychosocial point of view. We have a consultation group of integrate oncological integrative medicine. Well, the team, we have doctors, medical doctors. We also have nurses that are part of our group. The nurses support the patients and to us too, doctors, especially with the education component. And we also have the doctors that are the ones that make that first evaluation with the patients, talk about integrative medicine, and help them understand, depending on where they are in their oncological treatment path, how integrative medicine can support the patient. Sometimes the most important thing of the intervention of integrative medicine is not a therapy, but consultation. That is something I wanted to mention. If it is the doctor offering information and education on integrative medicine, or if it is a nurse, sometimes that's all the patient needs. Sometimes they don't need the massage or the acupuncture or some type of herb, but they need to understand what integrative medicine is. And they also sometimes need more information about the oncological treatment. And when the patient comes to the integrative medicine, they're probably looking for some alternate treatment. And just having this conversation with the clinical professional integrative medicine helps them understand why they have been recommended to have surgery or radiation or any other type of therapy. And that helps the patient to continue connected to the conventional treatment without missing the alternative treatments that are probably available in the community or in the internet networks. So let me go back to the concept of clinical lab. Throughout the last 10 years, we have had a program that is called IO Pro, which is the integrative oncology patient approach on oncology. As part of this evaluation, first they started completing them on paper, and then we went to tablets, so like an iPad. They fill out this information that is part of the clinical record and which is also available immediately to the practitioner, the clinical professional, for them to have that document ready to assess and see the symptoms the patient is exhibiting so that they can base the treatment, the education on that information that is available right there. And this same data is the one that we save on our database, and then we can use that so that we can have that assessment and on understanding why the patients have come to us and what is the impact of the interventions that we are offering them, a consultation or a treatment according to the symptoms they are exhibiting. An example of the first evaluations that we run using these systems with these reported outcomes was just to explore what are the patients, what are their interests of those patients that come to our centers, and what are the what are the most of the patients that have been offered these consultations. And it so happens that most of the patients that we have seen at our center have been women with breast cancer, and their interests have gone from the general integrative approach, questions about herbs and supplements, and also questions about nutrition. Those have been most of the questions patients have come to us. So now I'm going to give you some examples. It's going to be a little bit fast, but it is just to give you an idea on how throughout the years we have learned about each one of the interventions that we offer at our center: acupuncture, massages, music, therapy, psychology. Each interaction is an opportunity to learn. First, we start with the consultation that we have about nutrition and exercise. We recommend, in terms of nutrition, The data that we use to base our recommendation on comes from the American Institute research that is a plant-based diet, at least two-thirds of vegetal protein and one-third of animal protein. And we also recommend exercise based on the American College Sports Medicine that has recipes for exercises. And when we talk about exercise, and we offer a consultation on exercises with a physical therapist, we write a recipe to the patients, like as to how they can benefit from the exercise depending on where their journey is, if it is recently diagnosed or a patient that is in an advanced stage of their cancer. This is an example of a publication that we had, which is exercise counseling, that we counsel the patients on exercise during the treatment, and then we saw that before and after the consultation, that you say baseline and first follow up. So the first time we evaluate the patient, and then when we had the second experience to have an interaction with the patient, we identified improvements in symptoms, for example, fatigue. These, for example, we reported in the ASCO conference in 2018. We had two psychologists, Dr. Christie and Dr. Powers, and we have created some programs that have integrated nutrition, psychology, and physical therapy. And those programs that we have created, we find interesting not just to create the programs, but also share them with the other people. So there have been publications about this interaction that the various professionals have had as part of the integrative medicine group. Oncological massage is some specialty of massage where the massage therapists have an experience that is advanced on how to handle the needs a cancer patient may have. And we've also explored the benefit of the massages using that before and after assessments, and we've identified improvement on pain, fatigue, anxiety, and well-being. Also, using the clinical team that we have explored the way we can support the patients with other symptoms that commonly may appear as part of the oncological treatment. So our massage therapists will participate in an assessment where a specific treatment was offered as designed by our group to improve neuropathy in patients with breast cancer and gastroenterological cancers. This is using our team, not looking for additional funds for research, but using the experience of our team and having good strategy to keep data quality so that we can report on our experience. In intervention, additional interventions include mind and body practices such as yoga. We have meditation, yoga. These classes have been in person. More recently, they have been virtual too. And what we have done is each person that participates in the class, a patient, a caregiver, or a relative, they're asked before and after participating about the symptoms, and then re-report on the symptoms and the immediate impact of the class on the experience of these people participating in the classes. This is the study that we conducted on the impact of yoga on the patients and caregivers that were participating in our yoga classes. Music therapy. We also have a music therapist that's been a part of our team, and all the experience our music therapist has had, we told him anything you do, it's important to share with the rest of the people. So something that we recently did was we shared the experience our music therapist had to adapt music therapy that used to be in person to the telehealth model, to the virtual model, and we published on that experience. And this again is the concept of the clinical lab, where the experiences that we have, the data that we get as part of the management on the daily basis, we share, we publish, and it is also a good opportunity for all professionals of the integrative team can contribute to the literature, and they can feel part of this effort, global effort. Acupuncture, we've also had studies. We offer acupuncture for patients, outpatients, and the ones that are hospitalized, also using assessments such as ISAS or the assessment scale before and after the acupuncture. Outpatients, in outpatients, we have seen how the symptoms have improved with just one treatment regarding nausea, fatigue, and pain. We've also had the experience in decreasing or improving the symptoms in those patients that have acupuncture when they are hospitalized. Most of the improvement has been in pain with the study that we carried out. Now, to talk about the impact on this data that is created on the regulations, the National Comprehensive Cancer Network, there are some regulations that talk about how to handle fatigue in patients with cancer. If when we see what data was used to support this recommendation of a massage for fatigue in cancer, we found our study, the one that we ran of the assessment before and after the massage in the outpatient consultation, that the patients completed using the scale, and there was an improvement in fatigue, and the data that we use in our daily experience was the one that was used to in part to support the clinical recommendation that is available in the regulations such as the National Comprehensive Cancer Network. As part of our clinical model, we also talk to our patients. We tell them how to coordinate the management of different areas of health, nutrition, exercise, stress, sleep, and the various fatigue symptoms they may have or symptoms they have that maybe they are symptoms they had before being diagnosed or the result of the treatment. And then we talk about how the patient can benefit from integrative medicine, and help them support their health in these various areas. That is where evidence is important, not just the one that we have created in our programs, but the ones that also is there and created by programs like the catering. We look at the guides, the data out there, and using that information, we can create this prescription that is personalized for integrative medicine for our patients. Thank you very much. And thank you, Gabriel, for sharing with us such a holistic process such as that of MD Anderson. When we were planning this conference that we started many years ago, no, not years, months ago, I was asking Susana and Raul what areas they wanted to emphasize. Of course, Susana, research, and Raul made a comment. Maybe we could talk about how this is applied to the daily practice of medicine and oncology. And I think Gabriel has been very good in telling us how this can be applied on a daily basis to medicine and oncology. So, Gabriel, please stay with us because we're going to have a good session for questions and discussions. But now we're going to introduce our first speaker, Ricardo Ballesteros. He's a local player from Universidad Javeriana, and he's going to share with us some of his results, research. Ricardo, you have the floor. Good morning. Thank you, Dr. Alejandro, for this invitation. I'm going to present. Yes, I'm going to present. And I have the privilege of showing you the results of a clinical trial that we are conducting at San Ignacio Hospital with a fetal medication. Why do I say the privilege? Because as you can see, for this clinical study, we have a number of professionals and knowledge from medical doctors, oncologists, nurses, bacteriologists, scientists, immunologists, to organize and in a way bring integrative oncology based on evidence of of the natural products. In the presentation, I'm going to show you a little bit about the development of these natural products because maybe we are used to thinking about natural products as the ones we already know on a routine basis. But when we are going to use through a clinical rationale, they need to go through a series of stages as the regular chemical products. Let me start by saying that the rates of discovery for oncology are very low. And this has changed a lot by using immunotherapy because the results are faster, the clinical results are also more powerful, just as the rate that is handled for these products in all the phases tend to be really low. In fact, when you go to the FDA page, you can see that most of the research is in oncology and hematology. Very few of these products that start the process actually get to the clinic, and this is due to the fact that the treatment approach can be, in a way, be turn into a bad effect to the clinical life of the patient, and then it goes to the PRO. Yeah, it is very good. Survival is very good, but then that is starting to be articulated with the patient's quality of life, so that the new medication has very significant effects on the patient with good quality of life. And this all chemotherapy, and in fact when you ask AI what is the percentage of medications that are derived from natural products, in my head I had that it was like 40%, and AI is telling me that it is 50% of chemotherapy is related to natural products as the basis in the chemical group, or as an isolation from a plant. So we all know plaquetancer, anthracyclines, and all the derivatives that they have an origin in natural products. And a part of what has been changing throughout time is that tumoral cells have a series of characteristics that make them very complex to address. So sometimes the approach of taking just a molecular target tends to create resistant mechanisms in these cells. That's why you see that many of the oncological treatments are blends of different therapeutic things so that we can attack the various characteristics of tumor cells. Natural products, and when I say natural products, I'm talking about everything that can be gotten from an extract, which is complex blends of molecules and can attack the different molecules. And that is why the natural products that effectively get to oncology treatment go through very rigorous development processes that have to do with standardization to guarantee that all these molecule blends are always kept and the concentration in the batches is stable. And part of this is based on the Chinese traditional medicine, where we see that the patients that are treated with the standard treatment together with the integrative approach have better survival rates with better quality of life. And that is also associated that quality of life, better quality of life, results in better adherence to the treatment, because they say that they started chemotherapy, they felt worse, and they never came back. But we all know that that is associated to the intrinsic effects of chemotherapy. In the traditional Chinese medicine, there is a series of the doctors in this medicine, depending on the type of tumor, and in conversations with the clinical oncologist and the clinical group, they create the personalized prescription for the patient for them to take it at a specific time together with chemotherapy to empower the effect of the treatment and decrease the bad effect, the adverse effects. Natural products go through a more complex development process than those of chemical synthesis products. It goes from the collection process. It is not the same when I collect the plant if it is a sunny day, or if I collect it in the afternoon, or under the sun, or under the shadow. All that has to be standardized. After that, it goes through certification processes, heavy metals, etc., etc. And after that, it goes through production processes to isolate the blends of active, and that extract is the one that continues through the clinical path for those stability studies that I will get to in a minute. And all that is defined of the FDA's approach to ensure the therapeutic consistency of botanical drugs. And that was updated in 2016. And now the new vision of the oncological treatment is calling for a new update. If I asked you, how many natural products do you think the FDA has approved in the world, what would you say? Yeah, to be used as with clinical support in less than one. How much is that? Yeah, in fact, yeah, only two products have been authorized by FDA to be used in pathologies. One is for diarrhea in patients that have HIV, and the other one is for the human papilloma virus product. The rest is the none of the products that have been researched that have gone through. It is the fetal medications. That is one thing, and the other thing is the diet supplements, and another thing is the herbs that each one have an evidence level, traditional evidence, and also preclinical trials, and others that have been tested on patients with the regulations under, no, with results, I'm sorry, under all the regulations. This is what we call the P2ET. It is developed from DVD, which grows in Boyacá. There is a traditional use associated to this plant infusion as an antioxidant for sinus and against cancer. But one thing is herbs and infusions, and another thing is phytomedications. This is a process that has happened for about 15 years, where the vegetable material was domesticated, then it is brought to a pharmaceutical lab with best manufacturing practices, and then a sequential process for extraction is done to get the phytomedication, and then we study the stability. Here we have the chromatographic profile. Every time we create a batch, it has to be identical. And this is a challenge for natural products because any small change to the process can have an effect on the final result. After that, these are part of the results of preclinical results of efficacy. This is the evidence that needs to support, especially in cancer. These are some of the mechanisms. Basically, it is an immunomodulator that induces a phenomenon that is called the cellular death, which is like a signal for the immune system for the these to be recognized. I'm not gonna go into the detail. It's been used in different models of cancer. That there is a decrease on metastasis. There is a greater survival rate in these animals versus placebo on the standard treatment. And in addition, we run all the preclinical studies on toxicity, genotoxicity, acute genotoxicity. We got together with FDA and they told that basically you want to be out as photomedication. You have to do the same as a medication does. So you have to test that into animal models. You need to see that it is not genotoxic or mutagenic. And in 2017, when we met with FDA, they said we don't have to do pharmacokinetics. And then in 2020, 21, that we had another meeting, they said, yes, you have to do pharmacokinetics. So we went and did that with a phytomedication. These are some of the results. And now we're going to go to the clinical studies. This also was a challenge in Colombia doing this type of studies, phase one. We didn't have much experience. We have the support of the research center of Hospital San Ignacio, Dr. Pablo Ashner. This was a big group of experts. We had the first clinical study in healthy volunteers, and we found it was safe up to maximum doses of 600 milligrams a day, and that we needed to improve the pharmaceutical prescription. And then we got the pandemic. So when the rationale of these action mechanisms, the phytomedication could be effective in COVID patients. This is the publication of the group. This study was multi-center, randomized, double-blind, and controlled by placebo, and it was found that the patients in the phytomedication group had a reduction of hospital stay of 3 days and a decrease of all those of inflammatory markers that were known as the storm of cytokines that were decreasing the group that was taking the phytomedication, and there was a decrease of some populations of cells that were associated to lung damage and catastrophe of the patients with COVID. But in turn, we were designing the clinical studies, which is a phase 1/2B adaptative in patients with breast cancer. In phase 1 is to determine the safety profile. We had done that in healthy volunteers and COVID patients. Patients with breast cancer have some specific characteristics, so the safety profile needs to be determined. Dose that was going to be used in phase 2, and then in phase 2 we are exploring various security safety results together with the efficacy results that in this case we are exploring the response, we're exploring quality of life, we're also exploring survival and reduction of the tumor, many others that these are like the most important, if you will. Phase 2 is randomized, also placebo controlled, double blind. It will be registered in the clinical trial, and this is the study design. So today I'm going to show you the result of the phase 1 that have to do with safety and some for quality of life. In phase 1, we started with 6 patients on a 1,000 milligram dose that was obtained in the preclinical trials on animals. We need to do some extrapolations, and then with the results, we determine the initial dose, and they were given these doses to patients that were using chemotherapy for 2 cycles. If an assessment was run in the second cycle and they didn't have any toxic effects or adverse effects, then it was scaled up to 2,000 milligrams. If not, it was decreased to 500 milligrams. And then you continue with the anthracycline cycles. And if this would happen with 6 patients, which is part of this adaptive designs. For this, we have the help of Dr. Jing Juan from MD Anderson, a statistician that is working on these designs to improve the ease and decrease the number of patients that have very good results. Then we could start phase 2. The criteria for inclusion: women over 18 years of age with breast cancer that have a ECOG of 0 and 1, also that have documented progesterone, estrogens, and also to be eligible for coadjuvant or for treatments with other medications. These are some of the samples that we were taking for microbiome, immunological parameters. Quality of life is measured in all the parameters. This is an important part of the work done by the nursing group. And in addition, we take a biopsy when the anthracycline cycle finishes, and also the taxane cycle is finished, to see the tumor development these patients have. This is the first stage with 6 patients. These are the clinical characteristics. At that time, our two patients were not included, but after the first results with the clinicians, it was decided that there is no interaction. I forgot to tell you that the pharmacokinetic part, we had interaction with induction, and we didn't find a greater induction. So there was no interaction with chemotherapy or other supporting agents the patients were receiving.
At the security level events, all patients are to present security associated to the chemotherapeutic treatment. So the work of the clinical group is very important because they have to classify if the event was like a chemio or associated to the phyto medicine. But there were a total of 95 events, but none having to do with the phyto medicine. This is not innocuous, but the security profile of the phytomedicine is quite good. And in addition, this is always reported. There were no deaths and no patient deserted during the study. Something special happened. When the intervention finished in the 4 cycles, patients were told, okay, your intervention is over, and they wanted to take the phytomedicine. But no, because they're within the development of the clinical framework. This is part of the quality of life results. What we've discussed with all the group we're working with is that the quality reported in the articles is that the quality of life starts lowering when they advance in the treatment cycles. We found perhaps a little bit in the second cycle. The quality of life is maintained in the same points. Very good. When you compare the first one with the 4th cycle, the variation is 0.5%. This was done with scale QLQC30, which is the general one of cancer patients, and the QBR23, we saw a similar behavior where there's no variation in the quality of life reported by patients. Now, part of what we are measuring is this was expected with the anthracyclines, but part of the intervention is in interaction in spite of having all the results. And the 4th cycle, we also saw a decrease in the SOD, the size of the tumor. With those results and the platform given to us by biostatistic, we calculated the dosage of optimum blood juice, 2 milligrams per day. And with that, we started phase 2. Where are we now? We continue recruiting patients of phase 2, 8 patients, and our objective target is 25, in the placebo 25 patients, and we will start another clinical study with the extract of anamu. Perhaps you've heard about that plant, anamu. We 18 years have gone by. I've been just 8 years until be able to develop the phytomedicine. The preclinical security studies were done already, and we already designed protocol. We filed the papers in INVIMA, and we are waiting for the answer. All those clinical studies are recorded in the clinical trials platform. And in addition, we are recording the phytomedicine for the use of special pathologies as COVID result in Europe. And as of the results of phase 1, we improved the pharmaceutical formula. It is the extract of the phytomedicine, but it encapsulated with a Spanish company to have tolerability, availability, and security for patients, because some voluntaries had some gastric problems. So we have overcome that problem. With this pharmaceutical formula, we're having a study of equivalence to compare it with the previous one and to determine the dosage equivalent of nano versus phyto medicine initial one. And last, the gut ecosystem, we're working like 30 plants, each one at different levels of development to develop phytomedicines. and supplements with medical purposes in special pathologies. That's what I wanted to show you today, and thank you very much for your kind attention. Thank you, Ricardo, for excellent presentation. Another proof that youth can do wonderful things. As immunologist dedicated to oncology, I know how complex this is. And congratulations for this study. And please remain in the room to participate in the panel. We'll go to a Q&A session, and they can be virtual questions as well as the questions, live questions here. Raul, would you like to start with the questions? Yes, thank you very much to our speakers. It's been a very enriching session, and there's lots of things that can be discussed to what has been presented. I would like to start with general questions for Dr. Jung and Dr. Gabriel. Basically, in principle, I would like you to tell us a bit how the participation of the clinical groups of clinical oncologists, surgeons, education and research, and what do you have in your different hospitals in Anderson. Dr. Yoon, would you like to start answering this first question?
Me? You're asking me, right?
Uh-huh. Yes.
Right. I work in Memorial Sloan Kettering Cancer Center. I don't work in Anderson. Dr. Lopez does. So in our center, we really have I think over the years we have built very strong collaborations with our surgical, medical, and radiologists. For example, we have a study in collaboration with our thoracic surgeons to incorporate mind-body prehab to improve surgical outcomes. We're actually presenting in September at the SIO conference to show that with this program, it actually reduced hospital readmissions. We're currently planning a project with surgeons in the hepatobiliary surgery for people going through pancreatic surgery. And we also have studies collaborating with radiation oncologists and medical oncologists, for example, incorporating some mind body programming during radiation. And in particular, we're interested to tie in with the ongoing trend in using electronic patient-reported outcome. So when patients start feeling fatigued, how do we more efficiently guide the patient to use our online program rather than waiting the fatigue to continue to get worse? So we're trying to use different strategy. We're actually finding, actually if you had the referral bypassing the physician, more patients will participate because the doctors are just too busy to talk to patient about integrated supportive care. So this study is actually going to be presented at the annual Radiation Oncology annual conference as an oral abstract. It highlights there are a lot of things we may or may not require to help with patients. The more we can create a more integrative patient pathway without making physicians work harder, I think it's easier to get this kind of therapies used by patient sites.
Gabriel, ¿nos puedes comentar, por favor?
This question? Tengo muchas cosas en mi mente que se habló esta mañana y también lo que dijo. Can you please? Okay, that's why I didn't have a mic, so I couldn't hear you. Okay, thank you, Dr. Mao, for your perspective. And we do have some programs, we collaborate a lot, but have different aspects of how to handle the patient. That's what I always think it's fascinating that each cancer clinical center has different approaches on how they work. management and access to patients, how patients are referred among oncologists and different support services. From the clinical point of view, the things that have to do with integrative medicine have to be graduated by a doctor. So the physician is the one that makes the decision on how the doctor is doing and how he's going to benefit from all the different interventions and other possibilities there are for symptom management. Collaborations that we have had with other centers, for example, with the breast cancer center, we have collaborated with the surgeon group, the oncological medical center and breast center, and we've developed a change of lifestyles. So the evaluation works. Whatever we're assessed in the breast cancer center, we ask a question about the diet and exercise, and we also assess the index of mass, body mass. If it has more than 25 or they're not in compliance with the recommendations in the area of nutrition and exercise, that patient automatically they are offered integrative medicine. That's done with the nurses in the breast cancer clinic, and the patient will be ready. The change of lifestyle, then it's referred to the integrative medicine, and we continue this assessment process. And if the patient is ready for changing a lifestyle, like losing weight, we refer to our nutritionist or the physiotherapeutic for exercise, or if it's a stress or anxiety or lack of sleep that it's impacting its ability of changing his lifestyle, we also refer the patient to our psychologist. And there are programs like the ones I previously showed you that make to work together the psychologist, the nutritionists, and the physiotherapeutic for changing the lifestyle of patients. Another example of collaboration is the group of gynecologists, the cancer patients, one of the surgeons of endometrios of gynecology working in our center, assessing patients with endometrious cancer, endometrial cancer, and for those patients who are overweighted and have this type of cancer. So we recommend also to connect it with nutrition, exercise. We also talk to the patients, and if they have a pelvic pain, to work with physio, with yoga, for difficulties that they have to overcome post surgery. Another program developed for that population of patients, and we continue working. What we want to do now is to work with prostate cancer patients or the colon cancer patients, where we can coordinate in a more efficient way and patients to have access to this type of services. Thank you, Young and Gabriel. Here, the collaboration is key, and from the different fields. Talking about collaboration, it called my attention that Dr. Jung, as well as Dr. Gabriel, mentioned a lot the role of nurses in the clinical trials of research that you're carrying out. I know that in here the attendees there's lots of nursing students. I don't know if the attendees have any question. In the meantime, I would like that Gabriel, as you will describe a little bit briefly what's the role of nurses in your clinical or the research clinical programs. Gabriel, would you like to start? And then we will continue with Dr. June. Yes, an example of the importance of nurses has been in the breast cancer program. We even will have a presentation in this year's meeting where we will be talking about the importance of nurses in that program, of assessment of a change of life of patients in that center. It's a nurse that assesses the patient, asks him or her about exercise, motivation, nutrition to change their lifestyle. And the nurse is the one that has the first conversation with the patient, helping the patient to understand what's integrative medicine and what can be changed in the lifestyle that can have an impact, not only to improve the life of quality during treatment, but also how this type of intervention of a change of lifestyle can also improve the clinical results, the long-term clinical results, and lowering the risk of recurrence in these patients. So the nurse is the one that has the first conversation with the patient, and if it's thanks to that interaction, the patient will not come to our clinical center. Another important role where nurses have in our center is the hospitalized, the inpatients, where the nurse is the first person that assesses the patient, the inpatient, provides education, assesses, and determines if the patient can benefit or not of treatment like acupuncture, massage, yoga, music therapy that we have available for the inpatients. And it's the nurse that together with the physician coordinate the integrative medicine program for the inpatients. So we have an outpatients with the nurse, important role, and also for the inpatients and our outpatients. And our philosophy is that this is a clinical lab. The nurses participate actively in this clinical lab. Thank you, Gabriel. Dr. Yun, would you like to add any comment to this aspect?
Um, so I'm not going to repeat what Dr. Lopez have said. I think a lot is very similar. I want to emphasize a lot of our integrative medicine modalities, such as acupuncture, massage, yoga, meditation, really address a range of physical and psychological symptoms affecting cancer patients, such as chemotherapy-induced peripheral neuropathy, postoperative pain, nausea, vomiting, and those kind of symptoms are really the nurse play a critical role in management. As we build more evidence on the use of integrated medicine to address those symptoms, so I think really educated nurses or nursing students about the value of this treatment, so they can educate a patient and refer patient to the appropriate services is important. MSK, our nurse practitioners have dedicated patients during nursing orientations for all new nurses about integrated medicine therapy. So that way the nurses are well versed about both the evidence base and the availability of our services to help their patients. I do think this is a really important to make sure we don't just do the research, we actually find ways to disseminate and implement the research findings into clinical practice. Thank you.
Thank you, Doctor. Raúl, Ricardo, during his presentation, he mentioned as part of the study the security part, security of the products that are being researched. Something that it's very evident in all this complementary and alternative medicine is a perception of security that patients have regarding natural products. Many take in natural products because they consider these are products that have no second effect because they're natural products. So it will be interesting, Ricardo, if you tell us in a general way an overview of this concept of security of natural products. Obviously, the work being done, you saw all the complexity it has and the scientific rigorosity. Perhaps it won't be possible to have information of all the products that you use or we use in our community. I don't know if there's any way to progress on the knowledge about security of these natural products. That's a topic that it's very difficult with natural products because patients decide to have a natural product. They're looking for an effect, a result, but the effect cannot be innocuous. There's a recent study saying that many of the natural products used by the cancer patients tend not only to have liver effects, but to lower the chemotherapy. Cannabis, which is very common with cancer patients. A year and a half ago, we had a study. There was a study that certain preparations of cannabis lower the anthracycline effects, and this was done in a very thorough study. And at the end, there is no therapeutical benefit. So the first thing is, if a patient decides to use a natural product, they have to talk to their oncologist, the physician. Not only natural products, but in general, all the alternative therapies. Thus, what Dr. Gabriel was telling us, there is a interdisciplinary group that assesses the patient, that makes him or her candidate to receive certain intervention, and that has to be taken into account. The patient cannot be the one who decides in many cases for this type of interventions. Another thing to be taken into account is Colombia. It's a biodiverse country. We have like 83 plants that are authorized with therapeutical effects. But these authorizations are based on the traditional use. In other words, plants that already have uh, some years used in certain pathologies. But for pathologies like cancer, that it's the one we're treating right now, a rigorous evaluation of security should start to be implemented. In other words, models in animal models or toxicity, because it's not the same to use a natural product for 14 days than to do it for 90 days. It has a different security profile, those two. We've seen it in all the preclinic studies that we've been working on. So, to conclude, the first thing is to find out with the clinical group any decision to be taken. And if you hear from your different visions that a patient is going to use a natural product, you can tell them this is not innocuous, this can interfere with chemo. Another thing that I forgot is the natural products, the great majority of them have evidence in co-treatment. We've heard, perhaps you all know, patients that abandon treatment, chemotherapeutical, and start alternative therapies, as we've stressed and the two previous doctors too. This is an integrative topic. All the patient interventions have to be framed within a rigorous clinical evaluation. Going along that same line, Ricardo, but going to the future, we know you're working on the second phase. What challenges do you see for third phase? Those who have clinical trials, are the most complicated one, because in terms of people and participants, and you have to take into account the factors that we've already mentioned, efficacy, etc. So, what challenges do you expect, and how are you planning on dealing with that? I talked about the study, but this is a huge group. I'm just part of that huge group. An important challenge that we found is the recruiting of patients. Many patients decide not to participate. Many say yes, and then they withdraw. So to recruit and keep the patients, it's an important challenge. But part of that is the evidence shown. The patient who starts in a clinical study tends to have greater adherence, because there's a clinical group that it's paying attention to them, because they're within the clinical trial. Another challenge that it's not on phase 2 is the regulatory group. The times of approval of clinical trials in the country sometimes are too long, 4 months, 5 months, regarding compared to other countries. Because if we see this, the INVIMA, which is our regulatory entity, has done an extraordinary work. But perhaps we need to strengthen those times for when a clinical protocol is developed, that the authorizations be quicker with a rigorous evaluation as the one that it's being done. Thank you very much. Raul, any other question? that come from internet, and I know there are some questions here by the attendees. Allow me to read this virtual questions. But I wanted to, when you said about biodiversity there's in Colombia, I believe that's something important to recognize the difference between natural product created as a supplement and the strength and opportunities there are and what it's offered by food. And with the biodiversity in Colombia, there are huge and unique opportunities to explore how food can be incorporated in the quality of life of patients and to handle the symptoms of the patient without necessarily always thinking that you have to have a study with a extract. This is just food for thoughts. There are many opportunities to learn from what we already have without having to go through so many rigorous steps in creating a product when you can explore the positive and powerful effects of food. Very important, Gabriel. Thank you very much. I have several questions that are sent virtually. And these, for this case, are for Dr. Yun and Dr. Gabriel. One of them asked us, how do you see the importance of the physiotherapist in integrative oncology? If anyone would like to comment on this, you have the floor. Gabriel?
Okay, yeah. Sí, bueno, el fisioterapeuta o
Physiotherapist
kinesiólogo o kinesióloga,
or
como dependiendo
kinesiologist,
de cómo se define ese rol,
depending on how you define
clave
the
para
role,
el
is
programa de
key
medicina
for
integrativa.
integrative medicine
También me parece
program.
que es
I
clave
also
que
think it's key
colaboren
to
individuos
collaborate
que tienen esa
people who
experiencia.
have
Por
that
ejemplo, también
experience.
fisiatría es muy importante. Los grupos,
It's
los
very
equipos de
important, the
rehabilitación,
groups and the
poder coordinar
rehabilitation groups, to be
con lo
able
que
to
hace la
coordinate
medicina
with
integrativa en el
what the
manejo de
integrative
síntomas de
medicine
los
in
pacientes.
handling
Me
symptoms
parece
of
que hay
patients.
muchas
I believe
cosas que se hacen
there
en
are
común
many
y
things
muchas
that are
oportunidades para
common to
colaborar,
both and
estudiar
to collaborate and to study
juntos en el manejo del
together
paciente. Por
in
ejemplo, el
how to
manejo de
handle the
fatiga,
patient.
el
For
manejo de la
example,
neuropatía. Esas son
the
áreas donde
fatigue
muchas veces
management.
colaboramos con los colegas
Many times we
en
collaborate
los
with
grupos de
colleagues
rehabilitación.
in the
Nosotros ya hemos
rehabilitation
comentado
groups.
que
We have
tenemos
already
una
said that we have
fisioterapista que es
a
parte de nuestro grupo
physiotherapist
que
that
ayuda
is
a los
part of our group that
pacientes
help
en
patients
aconsejarle
and
cómo
advise
pueden
them
manejar la
how to
energía cuando
handle
tienen
energy
fatiga,
when they're
cómo hacer
fatigued
ejercicio de
and
una
how
manera segura.
to
Por ejemplo, un
exercise in a
paciente que
safe
tiene
way.
metástasis a los
A
huesos, que igual quiere
metastasis to
mejorar su
bones,
calidad de
and they
vida,
want to improve their
cómo
quality of life,
aconsejarle
how to
en el
advise
área
him or
de
her
ejercicio para que se
in
sientan bien, para que
exercise to
tengan
feel fine
ese
and to
tipo
have that
de
type
guía
of
que quizás
guideline.
pues, si una persona va a un
If a
gimnasio y
person goes
trabaja
to a
con
gym and
un
work
entrenador,
with a
pues esa
trainer,
persona no va a
that
tener ese
person
mismo
will
tipo de
not have
experiencia
that
para
same experience
aconsejar al individuo en
to
cómo hacer el
advise
ejercicio de una
the
manera
person how to
segura.
do it in
Entonces,
a
de nuevo,
safe
viene
way or
el tema de
secure way.
seguridad
So
y la
this
importancia
is
que
again
el
security and the
fisioterapista
importance
puede
of
tener
the
en términos de conocimiento
physiotherapist
para
to
ofrecer ese
have
tipo de
that knowledge
tratamiento
to offer
de
that
una
type of
manera segura
treatment
para el
in a
paciente.
safe and secure way for the patient. Okay, two more questions. We have participants from all sorts, professionals of dentists and phonoaudiology. They ask us, how do you see the possible role of a dentist in integrative medicine? And another one says, how do you see the role of the phonoaudiologist, a speech and language pathologist? If you know Jung or Gabriel would like to comment on this, you have the floor.
I think this is a more of about definition issue rather than role. I think integrated oncology, as currently defined, is more focusing on bringing like a traditional medicine together with conventional medicine in a very organized way and evidence-based way. I think if you broaden this definition to include everything, everybody, then it loses its definition, right? I do think if you think about, we should think about a person impacted by cancer, and that person will have any range of issues such as dental issues or hearing issues. often related to their cancer, and treatment can be exacerbated, right? Like, for example, xerostomia, the dry mouth related to radiation in head and neck cancer patient, can cause a lot of dental decay. So we definitely need dentist involvement. And some of the chemotherapy have neurotoxicity affecting hearing. So we will need our colleague in otolaryngology and hearing to help assist. I'm not saying they should be part of the integrated oncology based on definition. It's just because it's not what the definition is, but they should be absolutely involved in building the comprehensive cancer care for patients with cancer. And I do think it depends on the nature of the conference, because I'm not there. I don't know who are there, so hopefully I'm not offending the people who are involved. I think to help cancer patients to live and thrive, we need everybody who is committed to addressing the various physical, psychological, and spiritual consequences of cancer. So we work together to help the patient. I think absolutely those roles are very important.
Gracias, Jun. Esa es una excelente respuesta.
Young,
Sé
it's
que
an
hay algunas
excellent
preguntas de
answer. I
Centro
know there are
Presencial.
some other
El
questions
compañero de la
here
Universidad de
in the
Antioquia.
auditorium.
Sí, buenos
Colleague
días.
from Antioquia University.
Siguiendo
Yes, following
la primera pregunta del doctor
the
Raúl
first question
Murillo,
of Dr. Raúl
para
Murillo.
nosotros es
For
muy
us,
importante la
it's very
integración con
important
distintas
integration with different
especialidades, y
specialties.
medicina integrativa
And
requiere
integrative medicine
realmente
requires
sitios de formación,
training
posibilidades
places,
de hacer
possibilities of having access to
pasantías
training, student trainee
sitios
practices
en Nueva York,
in
en
places
Texas,
in New York,
donde,
Texas,
donde haya
wherever
posibilidad
there are
de hacer
possibilities
una
to
educación formal
have a proper
y
education
que eso nos facilite a
in
nosotros
order to facilitate
el acercamiento con otras
the coming closer
especialidades
to
en
other
medicina.
specialties in
Gracias.
medicine. Thank you very
O
much.
sea, la pregunta es,
The
qué bueno que
question,
trajo, porque yo pensaba hacerla también. Si hay
the question is if there
posibilidades, y
are
aquí
any
estamos hablando con
possibilities,
dos
and here we're
personas
talking to
que
two
colaboran con todo el
people who
mundo, lo puedo
collaborate
decir
with
con mucha
everybody.
sinceridad.
I can say it
Si
plainly.
habría
If
posibilidades
there is
de
any possibility of
colaboración,
collaboration,
incluyendo
including
pasantías,
trainees,
ese tipo de cosas,
internships,
tanto, porque
those
acá
type of
están
things. Because
pensando en
here
crear
they're
algunos
thinking on
programas de
creating
medicina
some
integrativa
integrative medicine
y quieren
programs,
que sean
and
lo
they
más
want to
comprensivo
be as
posible, tal como
comprehensive as
ustedes
possible
describieron
as you well
ustedes.
described
¿Sería
your
posible?
institutes.
Yo
Would
sé
it
que
be
ustedes no se
possible?
pueden
I know
comprometer
you
ahora mismo,
cannot commit
pero
yourselves
ustedes
right
ven
now,
eso como
but
una
do you see
posibilidad
something
de
feasible or a
colaboración,
possibility of
Jun y
collaboration in
Gabriel.
the future? And the question is addressed to Dr. Jung and Gabriel.
Yo voy a responder y me imagino, bueno, y ya veo que Jun que
Okay, so I'm
también va a
going to
responder
answer, and I see that
absolutamente.
Jim is going to answer.
Tantas,
Absolutely. There are
hay tanto interés
so much
en
interest
promover ese
in
tipo
promoting
de
this
educación
type
y
of
de
education
preparación.
and
El
training
Society for Integrative Oncology, del cual
in
nosotros
the
somos
SIO that we are
parte,
part
tiene una
of,
rama de educación
has
y
an
en este
education
momento se
branch,
están
and right now
desarrollando cuáles
they are
son las
developing
áreas
the
que son
areas
y muy
that are
importantes
very
para una persona
important
que quiere
for a
formación en
person who
medicina
would like to
integrativa
have a
oncológica, que tenga
training
conocimiento
in
en esas diferentes
oncological
áreas.
integrative
Del
medicine
punto
that
de
has
vista
knowledge in various areas. From the
de cómo
standpoint
nosotros
of
podemos
how
participar,
we
pues
can
una
participate,
invitación para
an
participar de
invitation to
manera virtual o
participate in a
presencial
virtual
y hay
or
diferentes
in
posibilidades
person,
y sí, yo con mucho gusto
and there are many
me
possibilities, and I would
comunicaría
be
con las
really
personas que
glad
tengan un
to
interés
get in
en
touch
que
with those
pues
of
venir
you
a
who have an
Houston
interest to
de
come
manera
to
virtual,
Houston
presencial o
virtually,
también
in person,
desde
or
Houston como
also
ahora mismo
from
también
Houston, like
participar en
now,
quizás programas en
participate in
Colombia
programs in Colombia also
que estén
that are
que tengan el motivo de formar a personas en el área de medicina integrativa y
that
entonces
have the
poder contribuir a
objective
ese
to
tipo de
train people
educación
in
también de
integrative
manera virtual o
oncology
presencial. Entonces,
medicine,
como
and also
de los dos
contribute
lados poder
in
contribuir
person
y
or
participar. Sí,
virtually,
eso
so we
es
can
una misión que
contribute and
tenemos
participate.
como parte de
That
nuestro
is a
programa.
mission that we
Gracias,
have as part
Gabriel.
of our
Antes que
program.
Jun
Thank you,
conteste,
Gabriel. Before giving the
en el
floor to June,
paper que
in the
hablamos ayer,
paper that
que
we
publicamos en CA,
mentioned
the Cancer Journal
yesterday,
for Clinicians de
that
Oncología
we
Integrativa,
published
en
in
cual Jun fue el
CA
primer autor
of
y Gabriel y
Integrative
yo fuimos
Oncology,
coautores y varios
and
otros,
June was the first
tocamos el
author, and
tema de
Gabriel
la
and I were
educación.
co-authors. We
Es
touched
importante
on
quizás
education,
Jun pueda hablar
so
un
maybe
poquito de
June
eso,
could talk
de
a little bit about
colaboraciones en educación.
collaborations in education.
So Alessandro, sorry, because of the conflict, I couldn't be there in person. I think it will be helpful to really figure out what the learning needs for physicians and other providers in Colombia. I think one of the immediate things, I think certainly with planning and collaboration, Sandra, hopefully you will be the bridge, and Gabriel and I actually were texting during the conference that we should do some research in Colombia. So with the pandemic, we actually have started doing virtual research training to physicians and trainees in Africa, in Korea, and in China, and India. So it would not be hard to replicate that for Colombia or other Latin American countries. Certainly, I don't speak Spanish, so our training has to be in English. So either we have trainees with a proficient, somewhat not perfect, but reasonable English skills, or Gabriel can join us. Our first project is trying to really train people to read literature, appraise literature, to identify the scientific questions, because doing research, the most difficult part is actually asking the right question. So now we're actually working with trainees to develop and implement survey studies to map out the survivorship needs in their local countries and communities, and then understand the attitudes, the barriers towards traditional medicine, and for symptom management. So with that, I think we're going to train some foundational research skills, and then the next steps to help to guide to develop small clinical trials that over time lead to large clinical trials. A lot of the patients and physicians want, like, I want a large study, like 300, 400. But to do it well, you have to start from the basic to really understand your population, understand what type of intervention may really work well with that intervention, and really carefully develop the intervention. Then those can lead to rigorous trial development. It does take time and commitment, and we're very committed to this process. Without the folks in different regions of the world doing this together, will never advance integrated oncology for global citizens. In terms of clinical training, if you have interest, as I mentioned, we do have online training. And my lab also accept postdoctoral training who are passionate about research. If you have decent English skills, you want to spend a year or two or even 3 years in your city, like working on projects, learning research, we have funding for that. So it depends on the needs. And I do think, Alejandro, hopefully you will communicate back our colleagues in Colombia what kind of specific things they would like to, and then maybe Gabriel and I can really jump on a call with maybe the leaders from the university to really figure out what would be a model that could work. Because in different countries and communities, the needs are different. We have to make sure to be mindful of those things.
Gracias, Jun.
Thank you, Juna and Gabriela. I was in fact talking to Dr. Susana and Dr. Raul about the opportunities and the interest you have in collaborating. And that is not always, I have worked in many parts of the world. That's not always available. So I think here we have big opportunity. In fact, I was talking to Ricardo a few days ago, and I told him that as soon as he graduates from his doctorate, it would be great if he could work with June and Gabriel in his postdoc. That would be a great opportunity. We have another question. Do we?
¿Sí está hablando? Okay.
Yes.
Buenos días.
Good morning.
Para el doctor John y
This
el
is for
doctor López,
Dr. June
quería
and Dr.
preguntarles
Lopez. I would like
si
to ask them.
ambos hablaron sobre
They
acupuntura
both talk
y
about acupuncture
electroacupuntura.
and
Y
electrical
me gustaría saber
acupuncture.
si
And I would
han
like to
encontrado
know
alguna
whether,
diferencia en
if
el
you have
efecto
found
a
any
nivel del
difference
dolor
in
entre
the
la
effect
acupuntura y la electroacupuntura.
pain-wise between these two.
Y la segunda
And the
pregunta
second
que me gustaría
question that I would
si
like
pueden
for them
responder es,
to answer
existe lo que es el
is
tratamiento
there
ortomolecular.
the
Quería
orthomolecular
preguntarle si
treatment? There is
existe o si
that.
han pensado
And
en
I would like to
incorporarlo
ask you if
dentro de
you
sus
have thought
centros,
about
este tipo de
incorporating
tratamiento.
this type of treatment as part of your
June, do you
the
want to
treatment
take
offered
the
by your
acupuncture one,
centers.
since that it
June,
is
do you want to
your
take the
passion?
acupuncture one since that is your passion?
That's a really good question. I think on a population level, we have never got really a funding to study electroacupuncture versus manual acupuncture. I tried. I haven't gotten it. I'm going to keep trying. You cannot do research if you don't have funding. At least that's in the United States. But we now have completed several large randomized trial. I appreciate you asking this question. This is actually going to be the analysis I'm going to do with the next paper. We have a trial to study sleep in cancer survivor. We use manual acupuncture, non-electric. Then we have about 40% of those population do have pain. So we're doing a subgroup analysis. And then we have a trial who study pain. We use the electroacupuncture. Again, about 40–50% have sleep issue. So we're going to harmonize the data set to do analysis for electroacupuncture versus manual acupuncture. So I probably will have more definitive answer maybe in a year or so for you. So my gut feeling is that overall electroacupuncture is better for pain, but that's with a caveat. We are also seeing when people have very strong expectation, meaning they desire acupuncture to work, actually lighter stimulation may actually work better than electroacupuncture. Again, we have to use data to prove my hypotheses. So stay tuned. I look forward to update group when we have the data analyzed.
Gabriel, ¿quieres tomar tú la
En este
segunda
estudio le puedo dar más información. Gabriel, would you like to take the second question,
Sí, con
please?
mucho gusto.
Yeah,
Pues
with
la
pleasure.
pregunta fue
The
sobre
question
los
was about
tratamientos,
the treatments,
la medicina ortomolecular, correcto.
orthomolecular medicine, right?
Pues la
That is correct.
medicina integrativa
So
es
integrative medicine
otra manera
is
de
another
manejar
way
el paciente. Entonces,
to
yo
handle
cuando
the
pienso sobre los
patient. So when I
tratamientos
think about
o
treatments
la manera de pensar
or
de un
the
tratamiento, una
way
estrategia
to imagine
ortomolecular,
a
pienso
treatment
que
or
es
an
otra manera de
orthomolecular
llegar
treatment, I
al
think it's a
mismo
different,
objetivo.
another way
Con la
to achieve
medicina
the same
integrativa
objective.
queremos
With
apoyar al
integrative
paciente,
medicine,
queremos
we need
mejorar
to
la calidad de
support
vida,
the
mejorar la
patient,
salud,
improve their
pero
quality
se
of
usan
life,
diferentes
their health,
estrategias.
but we use different strategies.
Pues la medicina
And
integrativa usa
integrative
una base de
medicine
datos,
uses
una
a
base de evidencia,
database
unas
and
intervenciones
evidence-based, some interventions
diferentes,
that are
por lo
different
general, sobre cómo se usan
on
en la terapia
how
ortomolecular.
they are
Pero no quiere
used
decir
in
que no hay oportunidades para
orthomolecular therapy. That does
colaborar,
not mean
hablar,
there's
ver
not
cómo podemos
opportunity
llegar
for
al mismo
collaboration
objetivo de
and
trabajar
talking about how we
de
can
una manera
achieve the same
segura,
objective
basado
of
en la
working
evidencia y mejorar la
safely
calidad
based on
de vida de
evidence
los
and
pacientes.
improving
Entonces,
the patient's
no es
quality of
decir que
life.
una
So it is
estrategia es
not to
mejor
say
que
that a
otra,
strategy is
son
better than
diferentes
the other
maneras
one. It's just
de
different ways
apoyar al
of
paciente y me parece
supporting the
importante tener un
patient.
diálogo, ¿no? Y
And I think it
entender
is important to have a
cómo
dialogue
estas
and
diferentes
understand how those
metodologías
different
se pueden usar.
methodologies can be used.
Tenemos una pregunta
We
más
have another
del
question
público.
in the
Puede ser
audience.
breve, por favor.
Please be
Gracias,
brief.
doctor.
Thank you, doctor.
Aprovechando que nos hicieron
Nah.
esa introducción de
Taking the
el
opportunity of having
grupo,
had the
que integra
introduction
el manejo de
on
los
the
pacientes
group that is part of
oncológicos,
the
en
oncological
cuanto también al
patients,
manejo de los
also
síntomas,
regarding
quisiéramos saber un
symptoms,
poco
we would like to
el
know
rol del médico
about the
especialista en
role
cuidado
played
paliativo,
in palliative
porque
care
nosotros acá, digamos,
specialist
en el
doctor,
hospital
because
tenemos
here
un
at the
centro
hospital we
que
have a
también integra
center
las especialidades
that
que
also
ustedes
integrates
mencionaron,
the specialties
pero
that
nos
you
llamó
have
la atención
mentioned, but
que pues, no se mencionó en el centro de
but we
ustedes
didn't
esta
hear
característica. Gracias.
the palliative care specialist. That was not mentioned there. Thank
Yo puedo
you.
comentar que eso es una
So I can say
conversación
that
que
that
me
is a
encantaría
conversation
tener,
that I
algo
would
que
love to have.
podría durar
And it could
horas y
take
días
hours and days
en la manera de colaborar
in the
con
way to
centros de grupos de
collaborate
cuidados
with centers
paliativos.
of groups and
Mi
palliative
entrenamiento, yo
care.
soy
My
oncólogo
training, I
paliativista
am an
y nuestro
oncologist and
centro de
a
medicina integrativa es
palliative
parte del
expert, and our
departamento de cuidados
integrative
paliativos,
center is part
rehabilitación
of
y
the
medicina
Department of
integrativa.
Palliative
Entonces, mi
Care
rol
of
es
or
como director del
rehabilitation
grupo de
and
medicina integrativa,
integrative
pero
medicine. So
colaboramos
my
mucho
role
con
is as
los
palliative
grupos de
expert,
rehabilitación
but we
y
collaborate a
cuidados
lot with
paliativos.
the
Entonces, siempre es
rehabilitation
importante
groups
ver
and palliative care
cuáles son las,
groups.
qué cosas son
So it is
similares, qué
always
cosas son
important to see
diferentes,
what
qué
are
puede ofrecer
the
un
things
equipo
that
que
are
no ofrece el otro, y
similar
entonces
and
entender
what are
de
the
nuevo
things that
cómo
are
se puede
different, what can
colaborar
a
y no
team
pensar
offer
que
that
es
the other
uno
one
o
does
el
not
otro, sino
offer.
cómo
And
todos
always
tenemos
it is about
experiencia, los equipos
collaborating
diversos
and
que
instead
pueden
of thinking
ayudar
about one
al
or
manejo
the other or how
del
we
paciente
all
en
can
diferentes etapas
contribute to
del
handle
manejo
the
del cáncer.
patient in
Ahora
the
mismo
various
en el MD
stages of
Anderson, el
cancer
grupo de cuidados
management.
paliativos se
MD
está
Anderson
enfocando
right
mucho en el
now,
manejo de
this
síntomas
palliative
en los
care group
pacientes
is
que están
focusing in
en
managing the
una etapa
symptoms
activa
on those
de
patients that
tratamiento
are
de
in an
cáncer, no
active
solamente en
stage of cancer
apoyar a los
treatment, not
pacientes que
just to
están
support the patients that
pues
are
ya con el cáncer
that have advanced cancer or that
eh,
cancer
yendo hacia
that is going
el
towards
final de vida.
the end
Entonces,
of their
es como
lives.
explorar
So
en qué
it's like
sitios, en qué oportunidades
exploring
hay
what
oportunidades
opportunities they can
que
find,
pueden colaborar estos equipos y ver,
opportunities to
pues empezar
collaborate
con algo
these
chiquito y
teams
ver
and
en dónde hay
start
esta
small
oportunidad y
and then
aprender más cómo
see
se pueden trabajar juntos, cómo pueden
how
trabajar
they
juntos
can
esos
work
equipos.
together
Ese es
and
un punto
learn.
bien
That is
importante
a
que
very
quiero intervenir
important
aquí
point.
porque
I'm
las
going
visitas
to
que he
jump
hecho a
in here
centros de
because the
cáncer
visits I've
en Estados
made
Unidos,
to cancer
en
centers in the
Argentina,
United States, in
Brasil,
Argentina,
está cambiando un
Brazil, is
poco
changing a
cómo se
little
llama
bit
ese
the way
servicio.
that service is
¿Por
called
qué? Porque se ha visto
because
en
it's been
estudios y
seen
hay
throughout
algunos papers
trials,
sobre
and there are
esto,
some
que
papers
la
about this,
palabra de cuidados
that the
paliativos siempre
phrase
tenía una
palliative
implicación en
care
el
always
paciente
had an
de que
implication
ya
to the
estaba al
patient
final
that
de
they
su
were
vida, que
at the
puede
end of their
ser,
life,
pero
which
otras
can
veces
be,
no.
but
Y hay
sometimes
una
that is not the
tendencia
case.
de que hay varios
And there is a
centros que le
trend
están
that there are
llamando
several
cuidados
centers that are calling
integrativos
it
o
integrating
integrativos,
or
de
integrative
apoyo, de
care,
soporte.
supporting
Sí, y eso no sé si acá en
care.
Colombia está
And I
ocurriendo
don't know if
también,
that
Raúl,
is happening
pero
here in
en varios
Colombia, Raúl,
lugares
but
eso
in
está cambiando
several
y es buena tu
places that
pregunta,
is
pero quería
changing. Your
también hacer
question
mención.
is good, but I just wanted to mention
Raúl, ¿tienes algún comentario?
this.
No, brevemente para darle la palabra al doctor Mao.
Just
Sí,
to
igual
give the
nosotros
floor to Dr.
cada
Mao,
vez adoptamos más
we
el concepto de cuidado de
are
soporte oncológico que integra todos
adopting more
estos
and more
elementos
the
que se han
concept of
mencionado,
oncology care
precisamente
that
para quitar
integrates
un
all
poco
these
el estigma
concepts
que tiene
just to remove that
el
stigma
cuidado paliativo alrededor
palliative care
cuidado al final de la
has,
vida.
which is
Y
end of life
coincidimos
care.
y creo que aquí
And
lo
yes,
hacemos de
we
la misma manera,
coincide
integramos el
and
cuidado
we
paliativo.
integrate
De hecho,
palliative care here too.
el médico de cuidado
In
paliativo forma
fact, the
parte de los equipos
doctor of
multidisciplinarios de las
palliative
juntas
care is
multidisciplinarias en
part
donde
of
se
the
decide el plan de tratamiento del paciente y
disciplinary
establece
team
ese
where
concepto de cuidado
the
desde el inicio
treatment
del
is
tratamiento. Le doy
decided.
la palabra al doctor
So
Mao
I'm
para que
going
nos
to
hable de la
give the
experiencia
floor to
en esta
Dr.
encuentro.
Mao so that he can talk about his experience.
I absolutely agree with both of your comment. I was actually the founding member of Symptom and Palliative Care Service at University of Pennsylvania before moving to MSK to take on this role. So I think the goals of integrated oncology and palliative care are sharing so many similar goals. So I think just due to the nature of the organization, often palliative care, at least in the United States, are often now moving to the terminology. More and more palliative care physicians are either themselves recommending integrated medicine or referring to us in a very active way. As a researcher, I just actually finished a large clinical trial of acupuncture versus massage for patients living with advanced cancer. So this trial is particularly novel in the sense that we are enrolling people diagnosed with an advanced, at least incurable cancer based on current line of treatments, but they have more than 6 months of life expectancy. With the modern precision oncology immunotherapy treatments, many patients diagnosed with advanced cancer are living for months, if not years. Is no longer immediately deadly disease. For many people, even with stage 4 melanoma, still a small group, they're even cured, right? As far as we know. So I think the definition of cancer survivorship, supportive care, palliative care need to continue to evolve based on the oncological treatment. But our shared mission and the job to take care of symptoms, improve quality of life, improve functions and resilience for people impacted by cancer, continue to share. And I really want to emphasize, I do think maybe we didn't, because Alessandro only gave us 15 minutes, so we couldn't touch upon everything. So, but I do think the collaboration is always very deep between integrated integrated oncology and palliative care.
I know you always blame on me. No,
Oh,
that's we are so good friends. Bueno, nos extendimos un poquito más, pero era que la discusión
Bit longer, but we had a fascinating discussion, and we had to give an opportunity to all virtual participants and those of you who were here. I would like to thank you, Dr. Jun Mao, from the bottom of my heart, from Sloan Catering, and Dr. Gabriel Lopez of MDA Anderson, and Dr. Ricardo Ballesteros from Javeriana University for having shared with us their knowledge and experience, and especially for having giving us the
Colombia
information as to them
participando
being
acá, así que
interested in
aprovechemos la
collaborating with
oportunidad.
Colombia.
No
So
sé
let's
si
take that
Raúl tienes
opportunity.
algunas
I don't know if
palabras para
Raul, you
ya
have
para
any
finalizar.
closing words.
Igualmente agradecer
I would also
al
like to
doctor López, al
thank
doctor Mao, al
Dr.
doctor
Lopez and
Ballesteros,
Dr. Mao and Dr.
y
Ballesteros.
resaltar
And
algunas
I
de
would
las
like
cosas
to
que se han
highlight some
mencionado
of
en
the
este
things
panel y
that
la
have been
necesidad
mentioned in this panel.
de un trabajo realmente
The need
integrado,
for
de un
an
trabajo
actually
colaborativo entre los equipos
collaborative
clínicos y
work
todos los que
with,
están
among the
dedicados
clinical
al
teams and
soporte del
of all
paciente
those that
oncológico,
are
la necesidad
devoted
de
to
trabajar en la construcción de
managing the
evidencia sobre todas
oncological
las prácticas que
patients.
tenemos
They need to work
y
on
obviamente si
collecting
queremos generar
evidence in all the
evidencia sobre la
practices. Of
eficacia, el
course, if we
tratamiento
want
en el
to
control de neoplasia
generate
areata,
evidence on
son un
these
poco más rigurosas, pero es lo
results,
que el
they
doctor Mao
have
nos
to
ha
be a
mostrado,
little
cómo
bit
es posible
more
construir
rigorous.
evidencia
But Dr. Lopez and
de una
Dr.
manera que
Mao
pudiera ser
have shown
probablemente
us how it is
más
possible to
ágil para
build
nuestros
evidence in a
servicios,
more
nuestros sistemas,
agile
y creo
manner
que eso
for
implica
our
también la necesidad
services
de que
and systems.
aprendamos
And
mucho
it
más
also
de lo
means
que son las
the need for
prácticas
us to
tradicionales
learn a
populares de
lot
nuestras
more
comunidades a fin
on the
de tener una
traditional
mejor base de
practices so
conocimiento
that we
para
can have a
poder
better
integrar de
knowledge
manera
base so that
adecuada
we can
ese
integrate
tipo de
this
prácticas en
type
el
of
cuidado.
practices
Muchísimas gracias
in care.
y
Thank you
creo que ha
very
sido
much, and
para
I
una
think
sesión excelente.
it's been a wonderful session. Thank you all. So now we're going to take a 10-minute break,
Volvemos a las 11
and
de la
then we will
mañana, hora
reconvene
colombiana,
at
para el
11
próximo
Colombian
panel que va a
time
estar
for the
también
next panel.
interesantísimo.
That is
Gracias.
also going to be very interesting.
One, two, three. We want to check. We're doing some.
Hi there.
Ya. Bueno, buenas tardes, buenos días. Vamos a
Good
continuar
afternoon
ahora con
and
el
good
segundo panel del
morning. We
día
will continue with the
y
second panel
vamos
of
a
today's
enfocar este en
journey,
un tema
and we'll be
superimportante
focused on an
que
important
es la
topic, which is
investigación relacionada a los productos naturales
importance of
y
natural
todos
products
los
research and
retos y
everything, all
oportunidades que
the
hay en
opportunities and
ese
challenges
campo.
we find in that field.
Tenemos cuatro
We have
panelistas,
4
van a
panel
tener 15
members.
minutos cada
They
uno
all each
y
have
después
15
vamos
minutes,
a tener
and
una
then we'll
sesión de
have
preguntas
a
y
Q&A
discusión
session,
parecido al panel anterior.
something similar to the
Para este
previous
vamos a
panel.
invitar
For this, we
primero al
are
doctor
first
Carlos
going to
Castro.
invite
El
Dr.
doctor
Carlos Castro.
Castro
He
estuvo por
is
mucho tiempo a
he
cargo de
was
la Liga Colombiana contra el
for many
Cáncer
years
y
in
trabaja
the
actualmente como
League Against
director
Cancer, and
médico y
he's
asesor de la
the
misma.
medical
La
director of
Liga
the
contra el
Colombian League
Cáncer, yo soy
Against Cancer in
testigo
Colombia.
de
I'm a
que es
witness
una
that
línea
it's a very
importantísima como
important
encuentran
line
los pacientes de
that
cáncer en su lucha
cancer
contra
patients
esta
have
enfermedad.
in order to fight against
Así
this disease.
que podemos empezar, Carlos, por favor.
Carlos, you have the floor.
Bueno, buenos días para todos y
Good morning to all of you.
agradecimientos para la Universidad Javeriana.
And I want to thank the organizers of this event, Dr. Alejandro and Universidad Javeriana. This has been very interesting in all regards. I have something that I was talking to my friend here. I've been more than 30 years as oncologist here in Colombia, and University of Canada, where I studied the traditional medicine. And it took us this, it came to this country, and we started talking about the trench, something that it's not taught in universities. And you start talking, hearing that people started talking about complementary medicine. That was 3 things, and this is a big term for everything. Things that we don't accept, like drinking the bird blood. That's something ancestral. And there are some people who go to the cemeteries and buy the birds to drink its blood. And they say they defend this because the birds never have cancer. I don't know who did that study because I haven't seen a dead bird with cancer. so they don't have cancer. I would like to see who is the biologist that starts doing those tests. So birds and sharks and everybody, and they killed lots of sharks in order to drink their blood. The same thing. And well, and they practice all these things with lots of animals. Unfortunately, many of these cases are just gossiping things. In the oncology practice on a daily basis, we see lots of gossiping, and that harms a lot of this. The GAT, what it means, this is generation of therapeutical alternatives. The generation of therapeutical alternatives in cancer. I thought that was an excellent acronym and definition.
Inteligencia artificial. Bien. Bueno, simplemente es rápidamente un recuento histórico.
Well, just some history. I don't want to take long because I want to hear Dr. Susana. Okay, so some history, because many of the things were already mentioned by Ricardo. This has been the evolution of cancer in the last century. 1900, surgery was very primitive. They didn't even use gloves. Things have really improved from what you first see in this picture and what we have today. This is history. That's the first irradiation pump. And the institution was called the Radium Institution. We had a war with Peru, and everybody gave money, and the women gave their jewelry to buy arms and things. Fortunately, the war lasted very few days, and there was money remaining. So they decided to have a radium institution, which was in fashion at the time. So they made this institution, and today it's called the Cancerology Institute. And I have a great regard for this institution. This is the masculine version of Dr. Susana. Researching plants back in 1955 in the National Cancer Institution. Alejandro has worked there, and they know what they've done there. Today, this is the National Institute of Cancer, and has different groups devoted to research, but this is what I wanted to highlight. A part of having enthusiasts, and that has been mentioned by Dr. Mo. Without any money, nothing. Unfortunately, this was a Nixon president who devoted some money for the cancer institution. I mentioned surgery, radiotherapy, and the systemic therapies, where we can talk about immunotherapy and lots of things that are in fashion. They are new and make the difference. This is what we already have, the therapeutical arsenal, more than 200 agents to control the disease called cancer. We have a lot of products that come from Mother Nature. This is just a timeline to show you since last century, starting from not having anything, and we started seeing that there were things that could be done. Even in 1960, for the first time, we talk about the possible cure of a malign disease, as we can remember leukemia in children. Back in 1960, it killed 100% of cases. A child with meningitis would die after 6 months. Okay, so the first steps were given, and there were things that could be improved. The wars always leave bad things, but in the Second World War, they started investigating how to terminate quicker ones than the others, and they used the mustard gas, which is a drug that has been good to cure many diseases, including lymphoma. This is just to tell you the evolution, how it has evolved, and immunotherapy, mortality by cancer started decreasing. The imatinib, it's a miracle drug. Well, this has been admirable development and continues each time quicker. This is the slide that I love the most, because it's the history of the evolution of lymphoblastic in children. From 1960, everyone died, and how year after year, or every 10 years, it improved. And today, in the USA, 80% of children with this disease are being cured. In Colombia, we come to 90%. We are reaching 60 or 70%, because we still don't, we have some room for improvement, but we are healing 80 or 70% of children with this disease. We could also mention lymphomas, the metastatic testicle cancer. If they said if you have metastasis, you're dead. But no, this cancer showed that this is something that could be cured even with metastasis. And this is just to show you. Ricardo was saying that he believed 40% of the medicines were of vegetable origin, but artificial intelligence said 50%. 40% of the medicines we're using with great success, all the diseases come from Mother Nature. So this is vincristin and vinblastine and vinorelbine. This is wonderful. The famous Taxus brevifolia, the ye tree. It's the formula that oncologists formulate the most, which is the Plaxitaxel. And in the past, it was Taxol because it came from Taxus, and the termination, which is an alcohol. This has given lots of benefits to this formulation. Docetaxel. And well, others, not just to stay talking about this. To these two people who were brave enough to they work in the USA, a place where there were scientific concerns, and they had this little tree. This takes like 100 years to grow, and to have 5 milligrams of the bark of this tree, it's very difficult. But they had the molecule, and today they are doing it or producing it synthetically, and it's very important for our arsenal. Again, to show you that the North American people have that concern, they have devoted lots of money to investigate products around the world. In China, China has a great amount of special substances. The algae have a great amount of beneficial things. I was reading, I asked artificial intelligence, there are like 25,000 products that have, that are in study, not all successful, but they are studying them. Chinese. These are natural substances from China. We have curcumin, lycopenus, pineapple, bromelias. Lots of things are nature-based, and perhaps we disregard, and we can use it in a beneficial way. So what you have is lots of work, Dr. Susana. I bring this because this is a marine algae, very important for sarcoma handling. And cannabis, it doesn't have a psychotoxic activities demonstrated, but it's good for cancer patients, for nausea and vomiting, etc., and pain relief. Today you can find cannabis everywhere. So that's very curious. But you have to add science to all of this. I'm enemy number one of the ancestral medicines, as Francis says. But those have to be respected, but also to research them, not just to listen and pay attention to everything we hear without any research. Last year, we assessed Ganoderma for cancer, and you go to any little town and we find that guanábana, which is the guava paste, which is, or the sap. It's wonderful, but they say it's good for cancer. All these things are part of a knowledge, and more than knowledge is like an ancestral idea or popular knowledge. As it was mentioned this morning, you have to pay attention, but let's organize this information. If that works, or it's just some gossiping, in order not to mix science with gossiping. These are blue scorpions. And this is only done in Cuba. That's made in Cuba. This is another thing that it's called the snake herb. It's interesting, but beware. See, homage to Dr. Susana Florentino, who I know her a lot for a long time, and Villa de Leyva flowers provide some oxygen to the brain. And the work she's going to present, she's going to talk about Anamo and Dividivi, but I wanted to mention this. I've been very pleased to see that there's several universities, perhaps I'm not mentioning them, but people from Universidad de Antioquia, National University, the Medicine School Juan N. Corpas, the UPT from Tunja and Univalle, and I think there are more. But it's so good that the Academy is paying attention to this important topic, because it's together with the academia that we can convince the skeptics. I'm not a skeptical person, but I'm not 100% convinced of things. I'm convinced of science and the scientific evidence, and we're working on that. And just to finish, how many secrets are there in the Amazon forest? Thousands and thousands of kilometers that have a spectacular thing. More than 130,000 species unknown, and perhaps we can find interesting things. I brought this picture of Pandora, which was mentioned yesterday. Pandora, according to the Greek methodology, was a beautiful young girl that was married to Prometeo, who made the crime of giving fire to human beings, and Zeus punished him. And this beautiful lady received this gift, and he said, "Don't open it." And she kept it. But as a woman, a curious woman, she opened it, and all the diseases from that or the evil from that box came out. And there was only one thing kept, which was hope. That's why hope is the last thing you lose. So I do believe in this university and all the studies you're carrying out. I think you can help us to discover new plants that can be good for handling this disease. Don't forget the paclitaxel from the plants that gave origin to one of the most important drugs that we have oncologists to treat this disease. Thank you very much. Estúpido.
Gracias, Dr. Castro.
Thank you, Dr. Castro. Taxel or Taxol, important for cancer, and it was the molecule as such was developed in the Cancer Institute in NIH for a long, long time ago. And it's good to remember Pandora. I will give a conference in Cyprus, where Aphrodite was born, and I'm going to look for the Pandora box. Okay, talking about cannabis, our next speaker is Dr. John Jairo Sutachan. He's the postgraduate director of a science faculty of Pontifical Javeriana University and principal investigator in the project Cannabis and Plants with Contraceptive Potential. John Jairo, you have the floor. Great. Good morning to all of you. Thank you for this invitation. I did a small change at the end of my presentation because I would like to show you a different vision of molecules we've been working with in the lab that have to do with neuronal plasticity. This is associated with the cognitive deficit in cancer, which is one of the works we've been dealing with in the lab and has important results to be shared with you. As Dr. Carlos said, the great battery of therapies we have right now, in spite of the cases having increased, they have contributed to the survival of patients. And this goes together with longevity. This has generated the appearance of symptoms that were not considered in the past. One of them have to do with the cognitive impairment. And this is an impairment that is generated by factors like chemio, tumors, the depression, pain that create then for these patients to have cognitive impairment. One of the most studied cases has been given in the breast cancer, where you find before treatment between 20 and 40% of patients have a cancer or cognitive impairment, and this goes throughout the treatment, and it increases 65 to 70%, and when they are in remission, 30 and 60% survivors report CRCI. So that cognitive impairment has several domains. For example, with regards to memory and attention, velocity, executive positioning, and learning and memory. So you can see that perhaps some patients do not remember information. It's difficult for them to interpret information. There's a deficit of attention, and there are learning problems. So this is, we are to consider that the survival of these patients, the effect is going to be significant. So we believe that in that field there's an important need. And other thing we think, in part, is that, for example, the tumor or chemio contributes to generate molecules that go through the barrier and activate the microbial cells, and then they activate the astrocytes that end up creating multiplication in neurons. The initial changes are mediated by plasticity structure. When I refer to that, let us see the neuron, and it's characterized because it has lots of branches that we call dendrites, and in those dendrites we have structures called the spines, and in those spines is where you find the different connections. So the findings in these patients is that there are alterations in the complexity of dendrites, and at the same time lower the amount of dendritic spines. These micromorphometric alterations can be translated in alterations of functional type that have to do with many of the events I previously showed you or mentioned. Although at the lab we started working for many years ago in looking for molecules or extracts that could have the potential to regulate that structure. This is based on a concept, and it's mediated by intrinsic genetic program, but also by extracellular signals. And we have this window to be able to act in the sense that in one way or another, if we modulate, we use molecules, extracellular molecules that act on neural activity or the diffusible cause that can contribute a lot to address those defects that are shown in neurons in the oncological patients. Now let's concentrate on a type of molecules called flavonoids. And the reason is because in this type of molecules present in many plants and food that we use, it's shown that those who have it have a very much better cognitive performance. These are the molecules characterized: two rings, phenyl, and one heterocyclical, and we modifications can be done in different parts of these rings, and that's what give birth to six different types of families of flavonoids. What we found many years ago, in 2010, 2011, when I came to the country, there was a library in flavonoid synthetic 678. I don't see it. Perhaps it's this one right here. Behaved similar to a factor, the neurotropic derived from the brain, molecule that has to do with plasticity mechanism at the cell level, but also functional level. Here, that shows the behavior of the flavonoid natural analog, which is this case, activates the tyrosine kinase and increase in the complexity. So we think Colombia, being a very biodiverse country where we have plants that can have a great variety of molecules, we should start looking on that side, those plants that had backgrounds on having some effect on the nervous system and very rich in flavonoids. Our idea of analyzing the capacity of the flavonoids extract or plants rich in these extracts to reduce the or induce the structural plasticity. This plan has been strengthened that Colombia Scientific gave to us through this GAT program. This is an example of passion fruit. We took the Passiflora edulis, and what we did in vitro was to try treat these neurons with polar extract. You see the results, no treatment, and down here the extract, and according to the concentration, low concentrations induce a significant increase, in this case in neurons. That's what we are seeing in this graph. These are the controls, and these are the branches neurons. And this other graph shows the analysis of the curve. Lower dosages induce this endogenesis process. Something interesting to highlight here, not only produce such an effect in endogenesis, but apparently there's an increase in the complexity of the dendrites. That's important because it's not only to induce branches, but also branches will be longer or shorter, or to have a change in soma. Something interesting, and you can see it here, there's a dosage effect. As you increase dosage, effect disappears, as we see neurons that have less branches but are longer. So there's a set of factors interesting to be explored in other pathologies. Another thing we did in this case was to treat these neurons and see what the extract was doing. We have the control. We cannot use high dosages because we will kill the neuron. So this is a 640 dosage, and this looks like doxorubicin, something that we want to evaluate a little bit with this type of therapies and certain coadjuvants, is that it do not affect the chemio, because we could be solving the cognitive problem but affecting other situations. So what we've done in lab together with
collaborators of Dr. Susana is evaluated whether we have antagonic or synergic effects of these extracts. And here I'm showing the results of our extract. For example, in the presence of doxorubicin on a tumoral line of astrocytes and one of neurons. And then you can see, because it is interesting because we see a synergistic effect. It is not antagonic, and it is good when we think about this molecule. So what we have done through Colombia Científica is develop this path line that will allow us to run systematic evaluations and that will allow us to assess whether there is secondary effect due to these extracts. What you want is to look at the mechanisms. And what we have worked with this has to do working with isolated flavonoids. And here, the sense of this is trying to look at the relationship between the structure and the function this flavonoid may have. And what we have done is work with quercetin and rutin, which are flavonoids that are characterized. Quercetin is the basis, and rutin is a modification that has a disaccharide that is made up of rutinose and also glucose. And what we find is that adding these two sugars increases complexity of the dendritic tree, and that does not happen with quercetin. So this change is important in a way. And we also find the same when we increase the dose, when we with the extract, there is a decrease in the effect. And if we look at this, this is a very branched out with a ramification. But if we increase the dose, then the neuritis are longer than the ones that we see here. So we wanted to see the mechanisms, and what we did was we assessed first if there was actually an effect related to time. If you look here, we have some early effects, 3 to 6 hours. Those structural changes are happening very quickly, and that suggests that these molecules work as a neurotrophic factor. So we looked at the signaling paths that could be activated, and we evaluated the MAP kinases paths, and then we saw a significant effect of the MAP kinase paths. This suggests that this compound works activating these MAP kinases roads, and we also found that this is a phenomenon that depends on calcium, because when we remove calcium from the solution, the extract stops working. So what the extract is doing is activating channels at the level of the neuron membrane, and then calcium will activate these structural plasticity mechanisms. When you think about those candidates that can contribute to inputting calcium, you think it might be related to these receptors, and then both receptors are being involved. So even though it is a molecule, it is just one molecule. Just think about it as it working at various levels in the neuron. And it seems like the effect is very specific to the type of cell, because when we evaluate whether the effect is present in the exciting neurons versus the gamma ones, we see that the effect is specific to the exciting exciter neurons, because it has some specific mechanisms that are related to the type of neuron. So what we think is that these molecules will activate the receptors, or like the NMDA and then kinases, which activate the signaling paths that induce these plastic changes. So the result was that whether we could improve in a way these types of molecules, and then we joined with the groups of synthesis organico from the chemical department, and then we made a modification in some flavonols. And what you can see here is that without a doubt these molecules are a lot more dendritigenic than the ones that we saw that were in their natural state. So we did some substitutions here with some groups that I cannot mention right now because we're trying to patent that. And what we can see is that depending on the dosage, complexity of the dendritic tree will increase. This opens a new perspective that we can work at various levels. We can work with extracts. We also can work with synthetic molecules that can have some perspective in a translational field. So what we can see now is that we need to continue working in generating the action mechanisms these extras and synthetic flavonoids have. And we also need to involve the other cells of the nervous system because the cell is not isolated. You have astrocytes and chondrocytes, and then you know that in the patient that has a cognitive impairment, those cells are affected. So that is something we need to work on. And without a doubt, to continue to be able to do this translational work, we need to work on preclinical studies that will involve the behavior of several types of cancer. That is something we're working on with Susana. So we are bringing that breast cancer model that she developed, and we are combining that with behavior tests to see if the molecules can revert, and then we'll see what happens later on. And something we noticed is that in Colombia, there is very little work with oncological patients. We did a first approach with the Oncological Center from Javeriana University to see whether the patients knew what might be happening. Without a doubt, that is something that it is not under the radar right now, not in the population that we assessed. And it was interesting to see that they were like, oh yeah, I started forgetting, I don't remember, I have more problems. And their caregivers would say the same thing. So there is the need to work on characterizing those patients because our oncological patient is not a common patient. It's a patient that travels to chemotherapy, goes back to their little town. I don't know what is their nutritional status and how that can, in the end, affect all these causes or consequences that the impairment. And I think somebody mentioned that before. I think those things we haven't worked on, and I think there is an opportunity for us to work jointly. To close, I would like to thank all the researchers that are from Javeriana University. Many of them are undergraduate students. The group of organic synthesis that is led by Dr. Alex, Dr. Andrea Riveros, and we started with bees to see if this has any potential in the cognitive area, and then Dr. Sionel Kim from Colorado State University, and also the program of Colombia Científica for their funding of this project. So thank you very much.
Gracias, John Jairo, por compartir con nosotros.
Thank you, John Jairo, for sharing your findings and part of your research with us. Now we're going to give the floor to Dr. Susana Fiorentino, who is the scientific director of the GATT project and also of the immunobiology group of Universidad Javeriana, and who was also instrumental for this course. Susana, you have the floor. Thank you, Alejandro. I'm going to, set the time because I always talk too much. Thank you all for being here, the ones that are here in person and those of you who are virtually connected with us. I am going to talk about something that I am directing the GATT program. My central focus is developing botanical drugs for cancer from plants. And next one, please. Oh, no, here, I can change it. I'm sorry. How do I change this? My conflict of interest, I am the founder and CEO of Dreembio, who's the startup that receives the medications that are developed here. This work started back in 2004. I am an oncologist and an immunologist. And when I was working in France, I found something that we had been studying for a while with my friend and colleague Alfonso Barreto, which is the role played by the activators of the immune response in a very non-specific manner, if you will. And there we got this idea. Cancer, as we all know, is a complex disease, right? Oncologists sometimes they look at it from a unimolecular standpoint, a gene that is altered and that is going to be solved with a single molecule. From the immunological vision and biochemical vision too, cancer has two elements that in my opinion are very important. One of them is the conditioning factor of the tumor cell, which is tumor metabolism, and the quality of the immune response. And these two factors that are conditioning factors and will generate mutations and alterations of the microenvironment alter this tumor microenvironment. If we solve any of these two, if we recover that tumor metabolism, we can recover the tumor microenvironment, and then the result is something that is very well known by oncologists and the clinicians, but more maybe by immunologists, which is the war phenomenon, where it was said that the tumor cells had a problem in consumption of glucose. They consume a lot of glucose. It was also said that the mitochondria of these tumor cells were altered, and that's why they were consuming a lot of glucose. Today we know that this has 50% of truth and 50% of lie, and it depends basically on the type of tumor. But we also know, and that is something very interesting, the fact that activation of the immune response will allow for good control of the tumor, the primary tumor, but mainly of the residual tumor cells. So this interaction between the immune system and metabolism has resulted in developing therapies that are recent, but that have been worked on for a while. I think it would be like 25 years that I was working on developing antibodies, anti-CTLA4 that hadn't gotten to clinic, and now they're there. And when they got here, it's been 20 years. That was 20 years after. And the last thing is how to inhibit those immunosuppressing signals the tumor will generate into the body. Looking at this complexity of cancer, then we find phytomedications. Given that it is a multi-factor disease, natural products, looking at the example of Chinese traditional medicine, natural medicines, since they are molecules that come from nature, of course, but when they are used as complex blends, they may have different targets on which they can act in a synergic manner. They can decrease anti-angiogenesis, apoptosis, autophagy, antioxidant, cell cycle arrest, and stimulation of the immune response. And using of that so-called Chinese traditional medicine in our region is called the indigenous medicine, and our Latin American people also. The idea is that that blend of compounds can regulate the tumor, and it can activate the immune response and eliminate the stem tumor cells. That immunological and oncological vision kind of clashes with what we have been talking about today. It is an invitation for each one of the professionals working in integrative oncology to do what they need to do. Scientists do science, clinicians work on patient management, but for all of us to talk to each other, for each one of us to try and understand and respect and talk from their own disciplines on how this basic science can result in improving the patient's health. Our basis, I'm sorry, here, our
disculpe,
Sorry,
es esta.
apologies.
Si la
Our basis
quimioterapia
for work
mata
is
las
this one.
células
If
tumorales,
chemotherapy
esta
kills, if
quimioterapia puede
chemotherapy
permitir una
kills the
activación de la
tumor
respuesta
cells, this
inmune,
can
la
activate
generación de
the
células que van a
immune
matar el
response,
tumor
the
y que
generation of
finalmente va
cells
a
that will kill the
controlar la
tumor and will
metástasis de las
control
células tumorales.
metastases of these tumor
Si yo
cells.
uso
If I
fitoterapia, que era la
use
hipótesis
phytotherapy,
inicial
which
de
was the
trabajo y
initial
sobre la cual hemos venido
hypothesis
trabajando
that
en
we
los
have been
últimos
working on
18
for the
años,
last 18
esta
years,
fitoterapia va a
this
inducir una
phytotherapy
muerte
is going to
tumoral de una
induce
forma un poco
tumor
más
death in
ruidosa.
a more
Va a
noisy
permitir la
way.
activación de las
It
células
is going to
dendríticas,
activate the
la
dendritic
activación de la
cells.
respuesta
It is
inmune,
going to
pero
activate
completa,
the
es
immune
decir,
response, the
no
whole thing,
solamente las
not
células
just the
CD8, sino las
cell
CD4 se
C8,
van a
but also
activar y
CD4
esto va
are
a
going to
generar
be
una memoria
activated,
inmune que va
but
a
this is going to
permitir
generate
la
immune memory
lysis
that
del
will
tumor, por
allow
lo tanto,
lysis of the
la
tumor
destrucción de
and
las
also
células tumorales
destruction of the tumor cells
que van
that are going to
a permanecer haciendo metástasis.
stay creating
Ricardo
metastasis.
entonces me ahorró una gran
Ricardo
cantidad de
saved a
diapositivas
lot
porque
of
habló de cómo se desarrollan las
slides
drogas
because he
botánicas.
already mentioned how
Estas
these
drogas
botanical
botánicas,
drugs
como
are
él lo
developed,
contó, pues
such
tienen un
as
desarrollo que
what he
es
said,
similar
have
al de
a
las drogas de
development that is
síntesis,
similar
pero
to
me
the
voy a enfocar en esto.
synthesis medications. So
Y
I'm
teniendo en
going to
cuenta
skip
esto,
this. And now,
digamos, este
considering this,
desarrollo y esta
that
conversación
developing and
desde
that
la medicina
conversation
tradicional
from traditional
hasta el
medicine
poder
all the
aplicar
way
estos
to being
medicamentos en los
able to apply
pacientes,
these medications into
desarrollamos en
patients,
GAD una
we
plataforma
in
de
GAD have
descubrimiento de
developed
drogas
a
botánicas que
botanical
va
drug
desde
discovery platform
la
that goes
etnobotánica,
from
pasando, digamos, teniendo
ethnobotanics
como ejemplo la
and having as an
farmacología reversa,
example the reverse
por un tema de
pharmacology
investigación básica,
through
celular y
a
molecular, en donde
basic
nuestro
cellular and
foco central
molecular
es el
research
metabolismo de las
where our
células
focus
tumorales
is
y la activación de
metabolism
la
of
respuesta inmune,
tumor cells and
lo
activation
cual
of
es validado no
immune
solo en modelos
response, which is
in
validated
vitro
not
en
just
células, sino
in
también en
vitro
modelos
models
animales.
in cells, but
Y
also
todos
in
estos
animal
datos que
models, and all
finalmente
these
son la
data
interacción
that
entre
are the
dos sistemas
interaction
complejos,
between two
¿cierto?
complex
Que son
systems,
los
right? Which
fitomedicamentos
is
con todos sus compuestos,
phytomedications with all
más
the
los
compounds,
datos de
plus
metabolómica,
all
de genómica,
the
de proteómica,
genomic,
que podemos
proteonic,
obtener tanto de las
metabolomic
células
data that we
como
can
de
obtain
los
from the
pacientes
cells
que entran
and from
a
the
los
patients
estudios
that
clínicos,
are part of the
son
clinical
analizados en
trials
unas
are
plataformas que
analyzed
estamos
on
construyendo.
platforms that we are
La
building.
plataforma actual se
The
llama
current
Oh My God,
platform is called
en
Oh My
donde
God,
se hace una
where
interacción,
we have an
un análisis de
interaction
esos
or an
datos que vienen
analysis of that
y una
complex data
predicción de
and a
para qué
prediction
sirven cada
as
una de
to
las moléculas
what
y
are
en qué
each of the
pueden
molecules
actuar. Y
good
además
molecules
hacemos
good for
conexión
and where
con
they can
otras
act, and
bases de
we also
datos
connect that to
existentes
other
en el mundo en donde se
existing
explica
databases around the world
cómo
where it
algunos
is
de los
explained
compuestos ya
how some of the
identificados en
compounds that have
Colombia, en
already been
Estados Unidos, en
identified in
América, en
Colombia, in the
Latinoamérica,
United States,
tienen
in China,
actividad en
all
diferentes
around the world have an
redes
activity in
de
various
señalización
networks of
intracelular o en el sistema
intracellular
inmune
signaling
y
or
esto
in
a
the
través de la
immune system.
inteligencia
All
artificial
this
nos
through
permite
AI
predecir
that
el
will allow
uso
us to
de diferentes
predict
compuestos
usage
que
of
nos salen
various
de
compounds
diferentes
and also
plantas
various
que
plants
tienen
that
diferentes
have different
composiciones químicas
chemical
para poder
compositions so
finalmente
that we
hacer
can
estudios un
in
poco
the
más
end
dirigidos.
run studies that
Hacemos
are
el
more
escalamiento, el
better
control de
directed.
calidad, los
We
estudios
scale quality
preclínicos regulatorios,
control, the regulatory
básicamente de los
preclinical trials,
fitomedicamentos, que son llamados las
phytomedications, which
drogas
are the
botánicas,
ones
lo
called
que no
botanical drugs,
excluye, como le mostraba
medications.
John,
What they
el
do not
aislamiento de
exclude
compuestos
is
que pueden tener una
isolation of
actividad
compounds that can have
antitumoral
an
específica.
specific
Pasamos por los
anti-tumor
estudios
activity.
clínicos,
We go through the
ahora
clinical
comenzamos en el
trials.
Hospital San
Now we're
Ignacio,
starting with Hospital
hacemos
San
estudios
Ignacio.
clínicos, como les
We
mostró
run
Ricardo, la fase
clinical
1, la fase
trials,
2, la
phase 1,
fase
phase
3,
2,
nosotros
phase
somos los
3.
directamente
We are
implicados
directly
en la
involved
escritura de los
in
protocolos
writing the
clínicos, los sometimos a
clinical
INVIMA
protocols and
y hemos
sending
establecido
them to
realmente
INVIMA, and we have
un
established
conocimiento
a
muy
knowledge that is
profundo, muy
very deep
competitivo a
and
nivel
very
internacional
competitive in
sobre
the
la realización
international
de clínicos
field
de primera fase
on
temprana
doing
y
clinical
obviamente
trials
queremos
of
llevar
early
todo
phases. And
esto
of course, we want to bring all
al
this
registro y a la
to
comercialización.
registration and
Con
commercialization.
esta plataforma,
With this
entonces, hemos
platform, we
desarrollado dos
have
medicamentos
developed
ahora,
two
uno más
medications now,
avanzado que el
one that
otro.
is more
Uno
advanced than
es
the
el
other one. One
extracto de
is
DVD
the
y el otro
extract
el
of
Anamu.
DVDV, and the other
Acá
one
vemos
is the
un poco la
Anamu
complejidad
extract. Here we
química
see the
de esta
chemical
medicina
complexity
botánica
of
que ya
this
deja de ser
botanical
en la época actual
medicine that currently
un compuesto con una
is
sola
not a
molécula, sino
compound
que se
with just
convierte
one
pues, en una
molecule, and it has become a capsule with a series of molecules that are clearly identified, where we know their stability, as Ricardo showed us, and which have been developed by following all these international regulations, where we go from the agricultural part all the way to the production of a medication, and following everything that has to be followed for chemical and biological stabilization. What is the central focus that actually has brought us to be believed by the clinicians? Because this would not be, this do not make any sense if we were not going to be used by clinicians. About 15 years ago, we ran a survey and we interviewed 25 oncologists. We asked them, what do you need? What do you want to know? For when the time when we develop a botanical medicine, you can recommend that medicine to the patients. And they told us, we need to know what's inside that. What are the components, the chemical components? We also need to know how they act. We also need to know if they interact with chemotherapy, and we need to know the results of the clinical studies, the clinical trials. And having run this survey, we started trying to understand this. With DVDV, just to show you as an example what we do, we identify what are the paths of activity of DVDV, the induction of the death of tumor cells through inducing stress of the reticule, apoptosis, liberation of ATP that allows for activating the immune response, the expression of the inhibition that is called Comeme, eat me. That's the name of the molecule. It shows the immune system that the tumor cell is dying in such a way that the response, the immune response can be activated, and then it says, eat me, and then it goes and eats it, and then it dies. And now, in collaboration with many of the Colombian colleagues in the United States, in Switzerland, we were able also to demonstrate that the DVDV's tumor activity only happens if you have a whole immune system. This is very important because when we talk about supplementary or alternative medicine, oncologists go there at the end of the patient's treatment when the tumor has already grown and oversight the tumor cells, when there is nothing, when it is not possible to recover the tumor immune response. So we see DVDV increases the ability of CD8 cells, increases the activity of CDB4 cells, and it also generates some cells that can reduce the tumor response. This is just to start introducing that not all natural products are the same. Each one is a different chemical world, and they have some unique tumor so a patient with a specific type of tumor cannot take the vulture blood or any medication of DVDB, but they need to have, this has to be scientifically validated. Anamu, which is our second medication, has a different function. It regulates the proteins that participate in the tumor metabolism. Anamu is a wonderful plant. It is a magic plant. It's taken us 15 years to develop this medicine, even though patients have been drinking this infusion for a while. There's reports of over 200 years of Anamu usage for cancer. It regulates the tumor metabolism. It alters the cellular cytoskeleton. You see? My alarm. Anamu as an extract alters the cell cycle, and it works as a cytostatic, and it decreases mitochondrial respiration or breath, and it doubles It double hits. It increases the activity, it decreases, I'm sorry, the activity of the mitochondria and also of glucose. So it kills the cells through two different paths. This is to show you that, for example, DVDV, which we call POET medication, and Anamu have activities in breast cancer models, and if we mix that with conventional chemotherapy, DVDV has an interesting action. It increases activity, but Anamu does not. So we don't always can mix herbal medicine with allopathic medicine. And in this case, and to go a little bit deeper, we run synergy or antagonism studies in 3D models to assess the effect of microenvironment in the interaction of medications. In leukemias, we see that DVDV does not have any cytotoxic activity. Well, breast cancer does. But if I put it in contact with roxadusine, it does not have any action. But Anamu has cytotoxic activity when we mix it. I don't do this. When we mix it with doxorubicin, we see that it has an activity that is similar and does not change the activity of the medicine. The synergy studies are expanded to several cell lines where we study each one of the phytomedications together with chemotherapy, and then we set our profiles of synergy and antagonism, and all this data is introduced in the Oh My God platform, which also after that are used to run the clinical protocols in a rational manner. This goes to show you another part of the studies that we run, and that is being able to research how the tumor microenvironment is different once it is treated with the phytomedication, and how each one of the phytomedications has a specific activity. In this case, we're working on a Tillandsia extract, which is the an old man beard. It says that it has no activity in the melanoma. Here, we see that animals treated with this extract, the tumor continues to grow, while the DVDV extract does reduce the size of the tumor. But in breast cancer tumors, both extracts have a very interesting activity. That is to say that these botanical medicines are behaving as individual medicines, as with a unique specificity, and they also modulate the microenvironment where we can analyze what is the role played by each one of the cells of the immune system and how those cells are moving after the treatment, and identify what are the molecular targets of this chemotherapy. Ricardo mentioned something very interesting. Lately, we have been encapsulating these extracts in nanoparticles so that we can make them more stable, for them to be more bioavailable, for them to actually become a medication. These are the results of nano encapsulation of a DVDV extract in zinc particles.
It is conserved in something much more interesting. The control of metastasis, it's much better with the nano encapsulated drug than with fit to medicine free. Technological, this is a progress, because part of the problem of development of botanical drugs is first, maintain its stability. Second, keep the effectiveness usage, its effect without interacting with proteins of the gut. The nano encapsulation can allow effects to be long lasting, always the same, and these medicines become distant medicines. With these medicines, we've developed clinical studies where I will emphasize the following. We have been able to identify that they really have antioxidative activity, but also immunomodulator that it's seen in the peripheric side of patients and tumors. In other words, what we see in rats, we are doctors of mouse. We start seeing them in patients. In the clinical study of phase 2, mentioned by Ricardo in patients with COVID, besides seeing that the patients have leave the hospital 2.7 days earlier from hospital, we see something interesting. The medicine reduce the pro-inflammatory cytokines, increase the cells that have antiviral activity, but reduce a very interesting population of lymphocytes that are the ones in charge of generating fibrosis. So this shows that phytomedicine is bioavailable in patients, and that bioavailability will allow us to see in cancer patients where we started the clinical study of phase 2B, randomized double blind, those effects about the tumor throughout time, the effect on quality of life, effect on metabolomic in patients, and microbiome of these patients, and effect in quality of life, on which I'm not going to concentrate because Ricardo talked extensively on this. We're going to start the clinical study phase 2 with Anamo after 14 years, not after 18 years, but 14 years. We're very pleased for this, and I believe INVIMA has done excellent work in the clinical studies room because they have taken the clinical study to other level. They're very much interested for this to work. Especially, I thank for this to come true and to be carried out, the commitment of oncologists to understand that these are medicines that can be useful in all the arsenal of therapy against cancer, with the comprehensive management that we're trying to focus on this course, thanks to the leadership of Alejandro, and that without any doubt the development of these botanical drugs not only will contribute to treatment of patients, but also will contribute to the development of new medicines in Colombia, in the building of a bioeconomy based on knowledge and based on biodiversity. And to continue this work, we are organizing a center of research on biohealth that will allow the development of all these plants that came from GAP GAP, where we have allies like Andes University, San Ignacio Hospital, the district secretariat, and of course I just want to thank the patients who have believed, and we hope they continue believing to participate in the clinical trials, to the Ministry of Environment, the different ministries that finance all the scientific ecosystem, the royalties system or institution that allow us to have this big leap to the clinical studies, and my team that have allowed us to put some science to the traditional knowledge. Thank you very much. Thank you, Susana, for sharing your knowledge and the effects produced in your lab. Now we'll go to our next speaker, Xuan Shen, Director of the Professor and Director of the Department of Cancer Biology and Molecular Medicine at the Beckman Research Institute in City of Hope, that works in California, USA. They have funds from NIH, and Dr. Shen will talk about his study, especially in the prostate cancer. Dr. Shen, you have the floor.
Thank you. So, greeting from
Muchas gracias. Saludos desde Los Ángeles.
hopefully everybody can hear me clearly.
Yes.
So somehow if there's a way to mute on my side for the Spanish translation, because otherwise I hear, yeah. So now it's fine. So anyway, thank you again for the opportunity to present. And, I always appreciate a meeting like this. There's a lot of work and behind it. Especially, I appreciate those folks that help the translation. I know those are difficult work and then going back and forth. So hopefully my presentation will be clear. So certainly for 15 minutes, it's hard to really go through everything, but I tried to highlight some of the stuff we had done, especially the lesson we learned, and hopefully that will be useful information for everyone. So what I'm going to focus my talk today is on the chemopreventive of white button mushroom in the prostate cancer. The first lesson saying that this is involved team's work. I want to show this all the people involved. Myself as the contact PI. We also including Dr. Trotsky as a medical oncologist focused on GU cancer. Dr. Lau is a urologist, a surgeon. Paul Franco, statistician and immunologist. Dr. Kotalaski and Dr. Wu is the urological pathology and the lab person, as well as the patient recruitment are very important. And Mari, the list here is basically help recruiting a Latino patient, and the manager manage the fund. And also, of course, I shouldn't forget all the clinical support staff helping patient recruitment and everything else as well. Of course, without patient, we can't really do this. And if I can advance the slide somehow. Yeah, so I have no conflict. So at City of Hope, as people may know that we're located in Los Angeles, that there's a famous quote that we always use. There's no profit in curing the body if the process would destroy the soul. So in other words, in addition with treating the patient, clearly we had to make sure and everything else that would be doing okay. And so that sort of point out actually related to these type of research. And City of Hope is known and care about patient, but for these so-called the involved the natural product, it probably maybe the major group to work on that. So I just want to share at the beginning of the lesson, and we hear a lot of these presentation. We're focused on the food. We're not really abstract. So we work with mushroom as whole. So, but the several things we need to keep in mind. Mechanism-based study is important. I want to point out that again. In other words, a lot of people doing cytotoxic effect, that's not the way to go. You have to have the mechanism behind it. The finding observed from in vitro study, animal study, and the human trial had to be interpreted properly. Unlike the other lesson will be the purpose of clinical trial had to be clearly defined. So, and the second lesson then, the study should go very long time. I wanted to show this first slide that actually came out from a surgical fellow and the summer student, because my role into this, and I was one of the first person cloned the human aromatase gene, which is gene convert androgen to estrogen, the male hormone to the female hormone. Of course, from that, and also see the development aromatase inhibitor, now is standard drug to treat estrogen receptor positive breast cancer. So with that in mind then, and see the side effect associated, and interesting asking the question, if in the natural product and our food there anything potentially can suppress aromatase, that was the ideal startup with this first publication in which the fellow decided to publish. I didn't think much, and actually just showed that among the stuff we tried, mushroom turned out to be the most potent one. And the next question everybody's going to ask, what the active component? Took us a while, then eventually we're able to publish paper in Cancer Reach to indicate the chemical involved in this process is chemical called conjugate linoleic acid. And so, one thing I cannot go into detail, I do provide the reference. Anybody interested can go into the look at it. And also take several years later, we actually now provide direct evidence, use recombinant, in this case, androgen receptor. We can show that these linoleic acid can interact with androgen receptor directly. This is using recombinant enzyme and act as an agonist and very little antagonist activity. I'm sorry. Yeah, so for the binding, then we can show the cell culture study suppression, actually the PSA production. So with that in mind, so I thought that would be nicer, like everyone else wanted to see if we can test in human and carry a clinical trial. And with this story, then I actually approached Dr. Totosky, who is a medical oncologist. I said, is there anything we can test? And he actually gave me this following statement, which I think is very important. I want to point out. So to identify the proper population, he said there's a group of patients in prostate cancer already has surgery, everything. So therefore, then they have really no symptom per se. But however, portion of those patients, their PSA increase with the time. That imply at some point then the cancer come back. But during that meantime, this group of patients really is under observation. So therefore, in this patient probably would be motivated to try these mushroom. So with that in mind, and we start this so-called biochemical recurrence patient. We initiate phase 1 trial. As everybody knows, phase 1 trial basically toxicity study show the product is safe, no toxicity. And to our surprise and are happy, and we actually see probably 1/3 of patient and see the reduction of the PSA at some point. And more interestingly, out of 36 patients with TAS, 2 of the patients then as indicated here, and we had to show the patient has a history of PSA arise, and after they taking the mushroom product, and actually the PSA dropped to 0. So it shows a complete response, and the 2 other patients are partial response, reduction after period of time, and the PSA came back. So in other words, these things tell us 2 things. One, the identification of patient population are very important, and take the advantage prostate cancer PSA measurement a standard treatment will save money on that side. And also with this result, we're quite excited. So with that, then we do have blood collection. We say, what do we see if anything else in the blood? Make a long story short, eventually encounter, we mentioned this type of cell called MDSC, myeloid-derived suppressor cell. These are the negative regulation of immune system. The MDSC usually goes up in cancer, will suppress the normal T cell function. We show intake the mushroom actually will suppress or reduce the production MDSC. And this table just showed the patient are basically doing fine, and except a couple of patients, they complain has the gas in their stomach. So from the phase 1 trial, we learned that then there's no toxicity. And because that reason, then the patient are highly motivated to take them. And with this positive response, and also the potential to see the impact on the immune system. And this is important. I want to show this slide, suggest that we talk about translational research. Very often we're referring to what we learn from the laboratory, we translate into the clinical trial or test on patient, but the translational research can go both directions. Here is one example here. For the exam, we're doing cell culture, doing animal, of course, or special cell culture, we don't know the impact on the immune system. But from the human study, we're able to find out the impact on the MDSC. So now we can actually go back, reverse translational to test this hypothesis to see what that really happening in the model system. Just very quickly, in term modulation, we know that with mushroom has this chemical called beta glucan, basically mushroom, and the cell wall has this basically, I'll say the sugar conjugate, and then typically it's sugar conjugate with the side chain And this can has immune stimulant effect. And we consider this as the effect of the mushroom. This is just another publication indicate that saying we compare the mushroom extract and these beta glucan, we can show this type of analysis impact on a lot of cytokine production. This is from an animal study and really showed the beta glucan can do the similar thing. All these cytokine release is affecting the inflammation. So in other words, this is again is a summary slide from this paper. You can look at it. At that point, and we got interested because people talking about in the male usually has higher incidence and easier get infected by the COVID than the female. Turned out to be probably not exactly clear at this point. But anyway, so this particular study will intend to show that mushroom can do two things at least we know. One is anti-androgen receptor, suppress this androgen regulate gene expression. And the other part then is really impact on the inflammatory response. So we thought this is worthwhile to report, but these remain in the laboratory study, the animal, we have not really gone to the human. So this publication actually came out support what we learned. It's a very important approach by this Japanese researcher. She actually carried out epidemiology study, indicates saying that in Japan, they did the study showed that in those men, this area, so actually intake more mushroom end up with a lower incidence of the prostate cancer. So I thought this is very important, really support what we learned. Now this is from epidemiology study. With all this information, we worked really hard. Fortunately, we eventually got funded by NCI for a phase 2 trial because the phase 1 really just study what is safe to take. And the phase 2 trial then actually will be 2 arms. The first arm is still dealing with the biochemical recurrence patient, but the second arm then actually involves so-called active surveillance patient. These are the patients now with prostate cancer. Many of those are slow growing. So while they're waiting, we thought that they would be interested in taking on the mushroom. And then these also involve control and the treatment group. And so in the biochemical recurrence, we can only collect the blood, but the active surveillance, we can get the blood sample as well as the biopsy sample. That allows us to carry out the correlative study. Without the time, and I will not go into details, but basically the primary goal, as I just point out, the PSA measurement, and then also then hopefully the exploratory arm can learn more of the mechanistic information. So this is the correlative study. And so with all that then, we had learned a few things. So I think this is an important slide to, at least to me. And certainly just the collaboration between the lab researcher, cancer doctors is important. In my situation, very fortunately, both Dr. Tutowski and Lau, they're training their urological medical oncologists and the surgeon, and they're willing to work with us. And the translational research can go both directions. So in other words, then you can learn from the phase 1 trial and provide some mechanistic information. The CAM product, this product with a minimum side effect will increase the compliance rate and the expertise is needed. So this is just one sentence. On the other hand, it's a lot of work into it. We want to make sure these products, there's no side effect. Otherwise, the first thing you discourage patient to take on them. So earlier I hear the conversation about recruitment. This is a key point. And the standardized product for the entire trial will reduce the error of the difference. So in other words, they will pay a lot of attention. If people are interested, we're really working with mushroom and the Lifelines product, remove the water, make tablet. We don't do any extract. So that's what we work with, and we provide patients with the same product. And so we had to go through the US FDA to get IND in order to get approved to use that. And this point here, identification of proper patient population and the use of definitive marker or defined marker as a measure of the clinical outcome are essential for a successful clinical trial. I cannot emphasize more. We want to identify the correct population to see. Hopefully you wanted to see, you can't really randomly just get a group of patients, and the defined marker is very critical. So I don't have time to get into it, but for people interested in this recent review, which is pretty comprehensive, we got into a lot of consideration with the various mechanism and then people need to consider. And also then with a different step, it start from the botanical and it goes through preclinical study, clinical development, all the consideration, which is, it worthwhile. If you're interested in, please go ahead, take a look. So anyway, I'll end with this particular slide. So I will say that started from the beginning, this is a teamwork. The two slides I want to show, this is at City Hall, but oftentimes we do fundraising. In this case, and it actually involved myself as researcher and the surgeon, and she actually was a patient and her father here. We worked together in order to work as a Chinese American or Chinese regionally, and we talk about dragon dance. I always like to use that. Dragon dance is a teamwork. We work together as team. You cannot do it by single person, and also this person leading this team will be critical. How you direct the team into a direction, hopefully productive way. That's very important. It's easy to say, but you do need to work to design. And finally, I want to thank the NCI support this particular phase 2 trial study allow us to do a lot of this work. With this, I will end it here and open up to any question you may have. Thank you.
Thank you, Xuan. Very interesting presentation. I have some specific questions that I've received. Some are mine because of my scientific curiosity. Susana, in your study that you're going on phase 2 of Anamu encapsulated, right? For breast cancer, right?
It's a tablet, yes.
Es una tableta. Es una tableta, sí, señor. Uh, for Anamu, we have not had clinical studies. The one that it's going to start is phase 1B. Patients with acute leukemia, gastric cancer, and pancreatic cancer. I doubt that I have. So, according to what I saw and the mechanisms you presented, as I see it, and I might be wrong, DVD had in cell immunologic action quite strong. Why you continue working with Anamu if you are seeing these wonderful results with DVD, or just to extend the possible botanical drugs? Well, tumors behave differently. Tumors are heterogeneous. Within a tumor, you can find glycolytical cells and others that do oxidative phosphorylation. The metastasis cells are more glycolytical, and they come from the tumoral niche and they migrate to the metastasis place and then phosphorylative. Anamu has an activity, interesting activity, on the active glycolysis cells, but also on those cells that have fragile mitochondria, and that can, because of their tumoral plasticity, they can become phosphorylatic cells. Anamu has that double action to attack both the routes of ATP generation, intracell ATP. So you prefer Anamu for the fragile mitochondrial cells, as well as the cells that have metastasis in gastric cancer, breast cancer. Metastasis general in this population, and there are some other tumors. DVDV has something wonderful. First, modulates the tumoral environment and the fibroblasts that favor the development of tumors are go back to normal fibroblasts because it reduces the radical oxygen and causes the death of cells for a mechanism that goes through mitochondrial, inducing the cell death and the immune response. The ideal of what we've seen, it's a combined therapy. 1 week DVDV, another week Anamus, so you can more or less attack all the set of tumoral cells. But we've seen with other fetus that there can be a third group of botanical drugs that might be between pepper and tillandsia, attacking metabolism as other factors that we haven't been able to understand yet, but they are kind of mixed. Thank you for the clarification. Seeing the study of Dr. Xuan has finished the clinical phase 2 supported by NCI, and probably it's going to phase 3 for prostate cancer. What opportunities do you see, Dr. Xuan and you, Susana, of any complementarity? Because seeing both studies, here are great opportunities. Dr. Xuan and you, Dr. Susan, comment on this, please.
Perhaps I'll start first. Certainly, yeah, this probably the first time I interact with, researcher in Colombia, and certainly looking forward to maybe more interaction. At least can start maybe exchange the information. Certainly, I'm happy to share what I have learned, and as a saying, and everything goes a long period of time. So certainly, if we can avoid certain things, that will be helpful. So.
Especially from Colombia, I do thank the participation of Dr. Chen that without knowing him would accept the invitation to the symposium. Your work is totally supplementary with what we do here. I would like to go to your lab and visit your lab with 2 people from my team to discuss the designs of the clinical studies, to show a little bit what is it that we're doing and how is the vision that we have here about the metabolomic of patients, the tumoral metabolomic, and how we can study this with with natural products. This is a wonderful opportunity to be able to extend our studies and to be able to come to have joint studies, clinical joint studies between Colombia and the USA, to go forward in this field that it's so complex and where you have greater knowledge, and that it's very much enriching for us.
Yes, thank you. Certainly looking forward to that. This day was the way with the Zoom meeting. We all get used to it. I think we can start from there. And rather than physically travel, unless you have interest to come to look. But certainly, yes, I think I welcome and start from there. So.
Yo creo que
the planning of this study, because we are open to opportunities. Susan showed me a paper of Dr. Shen on his work, and I thought it was fascinating. Talking with Susan more in detail, there can be an interesting complementarity, and that's how things come about. The courses and the workshops, that we can look for that complementarity in research in the certified area. So both have a good opportunity to exchange knowledges. I would like to ask John Jairo, because I've received some questions, which would be the next specific step in the relevant study that he shared with us. Excellent
That's a great question. I think that the next phase, which is the one that we are working on, is preclinical studies. We can, having the breast cancer model Susana has, we are going to treat these animals with doxorubicin, and we're going to develop the chemio brain, which is what you call this impairment, to see if we actually our extracts can reverse this cognitive impairment. And as I was saying in one of the meetings that we had, because a significant part of your study is related to cannabis and NCINH. 2 years ago, right before I got retired, they gave me that challenge because we weren't doing almost anything. We were doing almost nothing in cannabis and cancer. Now we have three grants, and one that is entirely, I would like you to look at it because it is in biological sciences, it is in cannabinoids. I think there is a lot of work to be done. That study is going to be recompeted, and we can bring you in touch with the program officer and start looking, because that's how we start. Because there are three grants. One is in politics, because that is a problem working in cannabis, but there is another one that belongs to the biological sciences, from the Division of Biological Sciences for cannabis and cannabinoids. In that case, we're working with cannabinoids and pain. It's been very interesting because, without a doubt, the difference between extracts has different effects in the regulation of cannabis that regulates pain, and it's also specific to the type of cell. So yeah, we're open to that. Of course, we will continue. We will keep in touch. So I think we need to start closing, but I would like to say that with us we have research groups from Córdoba, Argentina, Buenos Aires, Ciudad de la Plata in Argentina, from Cali, Colombia, Tuluá in Valle del Cauca, Colombia, from Risaralda in Pereira specifically. So, and also a group from Texas. Between yesterday and today, we've had 600 people participating. And today it flowed very well. Thanks a lot to the technical part. And we have received a lot of comments. We've been able to keep your interest from 9 to 12:30. Thank you all for being here, virtual and in person, all speakers. It was great. We learned a lot. And tomorrow we're going to talk about the opportunities for training and the opportunities for research, talking about specific topics in financial and funding opportunities. And we're going to get NCI and IH people, from IAR people, and also we're going to hear about a cadastre that was done from Canada to Tierra del Fuego. So see you tomorrow at 9 in the morning, Colombian time. Thank you all, and have a great afternoon.